Okay. Um, so I did pretty much the ones that I thought were the most important. But I put a little box over here just to remind you that also people covered parasympathetics during this block. Um, I think I did them in cardio. I can't remember when I did them. I didn't do them here just because I didn't know if you've done it in a previous block, but just don't forget that those some of those have like your anticholinergic effects. You should review those, like just little things like that. We can do it later. Like I said, we can do that later. I also didn't do the Parkinson's meds because I think it would have been too much. I think these are the most important ones. But I think there's also Parkinson's and parasympathetics were kind of the only ones left out. And so kind of how I study farm is I do charts. So that's what I did for you. I made charts and then questions. I think charts and questions are like just the best way to review farm. So that's what I did for you. Um, but and then I put like the drug name, what class it is, mechanism of action, indications, and notes. And what I was trying to do was you should 100% know the mechanism of actions. Like if you're doing any farm questions, you'll probably see that's what they're asking is like mechanism, but they also will ask indications. Um, but I wanted to put like a little star by indications. I didn't do it because the other thing is they'll never ask you like what drug should you give this patient. What they'll do is they'll explain like a psychiatric condition, like they'll explain like I don't know, someone has generalized anxiety disorder, and then it's like the most common medication given for this condition acts in this way. So you're sitting there and you're like, okay, it's very like third order level kind of reasoning. So if you know like what the number one drug for generalized anxiety disorder is, you will know that answer to that question. Okay, because then they'll tell you about the mechanism, or they'll give you like a side effect, or they'll do something like that. They'll never ask you, and I've never seen a question where they're going to be like, which drug should you give this patient? But it's still good to know. So some people are like, oh, I don't even study indications. Like, I don't study what. And I'm like, it can help you in the problem though. Like, they'll tell you, like, oh, the most common drug for this condition acts in A, B, C, D, E. Which of these is its mechanism? So you still have to know it, but yeah, they'll never ask you which drug do you give for generalized anxiety disorder or for status epilepticus or whatever. But that's why I included it here because it will help you. Okay, so starting with sedative hypnotics, and again, this is more so for you to study, but the important ones is you should definitely know the names. And because like sometimes people just study like, oh, I know like these are sedative hypnotics. And especially when you get to the antipsychotics, like the first generation antipsychotics, um, I kind of group all of the first generation antipsychotics and I just study that, right? So I'll study like, oh, that's how they work in this way. You give them for these things, and here's like notes on them. But you need to know like, oh, if it says like Halidol, like you need to know that's a first generation antipsychotic. So you do need to know the names for which type of drug they are. Like lorazepam and oxazepam, these are sedative hypnotics, and the class is benzodiazepines. Does that make sense? That's why psych pharm is so difficult. I don't think the drugs are difficult. I think it's just there's a lot of names. Like there's just a lot of names. Like you need to know it's a sedative hypnotic. It's like these are the names for them and they're benzos. Because then it's like, oh, okay. Like these are, you know what I mean? Because they can ask any one of these. They can give you lorazepam. They can say in the question, oh, your patient's on a sedative hypnotic, or they can say your patient's on a benzodiazepine. And you need to know all of the like you need to know that this is for all of these. Okay. So lorazepam, oxazepam, you have your PAM suffix. That can kind of clue you in that it's a sedative hypnotic. Triazolam, alprazolam, midazolam. That's your olam suffix. And then the other two are like chlordiazox, oh my God, diazopoxide and diazepam. I know this has the PAM suffix, but I kind of group them in this way, just based on their class. So all of these are benzos. So they're short and long acting. But then these guys are going to be your short actings. And then these guys are going to be your long actings. So that's kind of how I grouped it. And that's also important to know because sometimes it'll ask, like, okay, when do you give a short acting one? When should you give a long acting one? Um, which it'll usually just ask you in the prompt, like you want to give a short acting benzo, or you want to give a long acting benzo. It'll tell you and it'll clue you in on which ones it's talking about. Mechanism is important for all psych drugs, so especially benzos versus barbiturates. They kind of like act very similarly, but they have a different kind of what they do is different. So I highlighted that in yellow. Things that I highlighted in yellow, I like very specifically remember getting questions on. So that's what I tried to do. Some slides you'll see like the antipsychotics, like they ask so much about antipsychotics. So that slide has tons of yellow on it. So mechanism, they're going to bind to an allosteric site on your GABA R receptors. And remember, GABA is inhibitory. It's your inhibitory neurotransmitter. And it's binding to an allosteric site, which is also kind of important to know because it's not binding to the actual binding site of GABA. It's like binding to this regulatory site. And sometimes I feel like I also got a question on that. It was like, where is it? I think it was like a complex question. And it was like, it's not binding in the active site. It's binding on this random allosteric site. So it's binding there, but when it binds to it, it's not blocking it. It's like potentiating it. So we're getting potentiation of inhibition, which is kind of weird to think about, but you're basically activating inhibition because this is an inhibitory neurotransmitter. Also with GABA, it's a chloride channel. So sometimes they'll ask about that, like which, ion is responsible for GABA's actions. And then lastly, the important thing is what does binding do? So we talked about how it potentiates GABA's inhibitory response, but what it's really doing, these benzos binding to GABA, it's increasing how frequently the channels open. And you can remember like from Sketchy, like there's a sign, like they talk about like the frequency, like it's open more frequently for the benzo. If you haven't done that one yet, they really go into like remembering that benzos increase frequency because barbiturates also bind GABA, but they don't increase frequency. And I would be shocked if you didn't get a question where they asked you about a benzo or a barbiturate and both answers were there. One increases frequency and one increases, I think, closing or something. Okay. So benzos are going to increase how frequently these GABA channels are opened. So if they're open more, they have more of an inhibitory response. So why would you give this? You would give it for alcohol withdrawal. They'll never say that a patient is experiencing alcohol withdrawal. They're just going to give you symptoms. So I put them here. So the common ones, like 8 to 12 hours, if you're an alcoholic and you don't have alcohol, you can have insomnia, tremors, and anxiety. But then like 2 to 4 days later, you can have delirium tremens. And this is going to be like fever, disorientation, and severe agitation. This is like life-threatening. That's why, like, remember when COVID hit and like everything was closed? You couldn't close down liquor stores because you could literally kill people that were alcoholics because they can go through this withdrawal. And then some of the other stuff, so seizures, anything that you can imagine that like the brain is being hyperactive because this is like an inhibitory kind of drug. So seizures, you can give it for some anesthesia. You can give it for insomnia, but a note here is that it's not first line for insomnia because there's dependence. So you can get benzo dependence. And you've heard that. Like anytime you see that someone can like die from overdosing, people overdose on benzodiazepines all the time. I think Elvis, I think Marilyn Monroe, I think like a lot of people overdose on benzos, and that's why, because there's this dependence aspect. Same with opioids. Same thing. It's like they think they can take more because they're not getting as much of a high, and that's what kills them, is because they take more. So that's usually an indication that there is dependence. You can give it for parasomnias, spastic paralysis, again, anything where it's like the brain's freaking out. Sedation. It's interesting though because it's conscious sedation, so you're not totally knocking the person out. You're not giving them like an anesthetic. This is like you're just basically they're still awake, but they're not going to remember anything. That's conscious sedation. And then you can use this to treat like generalized anxiety disorder and panic disorder, but again, it's not first line. And I always put first line because again, like they said, what's the most common drug for this condition and what's its mechanism? That's usually what they'll ask. Okay, so that's what you give it for. And then my notes. You can give it IV for all of these things. Alcohol will bind to, so another interesting thing is you definitely cannot take this with alcohol, like absolutely not. And the reason why is because alcohol also binds to GABA, to an allosteric site, but it's not the same one as benzos. But you can imagine if you're you're drinking alcohol and you're also taking a benzo, you're shutting down, like you're basically like not allowing neurotransmitters to like, you're not allowing anything to happen in your brain. It's just total inhibition everywhere. It gets metabolized by the liver. There's potential for addiction. There's a potential for tolerance. And this is kind of what I mentioned. Again, a good way to think about tolerance is like if you know of anyone that has overdosed on that drug, it's probably because there's this tolerance aspect. So GABA receptors will start to get downregulated. So again, they need to take more to experience that same high, and then they'll die, unfortunately. Some side effects, you can get anterograde amnesia, which is like you're going to forget things in the future, like things that are happening to you currently, not retrograde. So like current things that are happening, you'll probably forget them. And then central ataxia. And then avoid in elderly patients and patients that are on other depressants, again, including alcohol. But here's some other, like, central nervous system depressants. So first generation antihistamines, alcohol, barbiturates, and neuroleptics. These are all going to also be like downers or depressants. So you don't take, because again, you're just going to get total inhibition in your brain. And this is a really important thing. Anytime that it can cause a condition that can be reversed with another drug, know that. I think I actually made a chart about that, like when I was studying for boards, because it came up so frequently. And I also guarantee you will get a question. Like, so if you get benzodiazepine-induced sedation, and it's like, how would you reverse this? You give flumazenil, and it acts competitively at the benzodiazepine receptor. So 100% know this, and just know, anything in yellow is, they'll probably ask you about, honestly. Those are your benzos. Those are the names for it. Just don't forget, like, you hear that name, you should be thinking, okay, that's a benzodiazepine. If it's one of the short-acting, it's a short-acting one. Long-acting one. The next set is going to be your non-benzodiazepine hypnotics. So we're still doing sedative hypnotics, but these are your non-benzodiazepine. So they're not going to have the same like effects as benzodiazepines. And these are going to be your Z ones. So all the Z's I highlighted, made bigger. And I remembered like in the sketchy too, it's like the ZZZ. So that's going to be your zolpidem, zaleplon, and azopliclon, or zipliclone. I don't even know. But these are your non-benzodiazepine hypnotics. So like think about things that can help you fall asleep, but they're not like benzos. They do bind to the same allosteric site as benzodiazepines. So they're binding to that chloride channel, or they're binding to that GABA receptor. But they're not, acting as like intensely as your benzos. So basically the point of giving this is, remember your Z's, these are your Z's. So think sleep. So give it for insomnia, or sleep onset insomnia. So basically sleep onset insomnia is you can fall asleep, but you can't stay asleep throughout the night. You can just take one of these. And then zolpidem and zaleplon they act very quickly. In general, these drugs have a short duration of action. They get metabolized by the liver, much less likely to cause dependence and withdrawal. Again, they're like lesser benzos, basically. They can cause similar things as like I still have pretty much all the same things here, and you still can reverse it with flumazenil. Okay. And this is like your classic, like when you hear people like overdose on sleeping pills, it's probably one of these. These are probably one of the sleeping pills that people can overdose on. Okay. Next, we have melatonin and Rameltian. Yeah, these are your barbiturates. Are they? Yes, I think. I don't even know. But anyway, they're going to bind to MT1 and MT2 melatonin receptors located in the suprachiasmatic nucleus of the hypothalamus. So remember that the hypothalamus, the suprachiasmatic nucleus is, the pineal gland. Let's start with the pineal gland. The pineal gland releases melatonin, and where does it go? It acts on the suprachiasmatic nucleus of the hypothalamus, and where it's binding to melatonin receptors. So MT1 and MT2, these are your melatonin receptors. And basically just when it binds to it, it's going to activate, it's basically going to cause you to go to sleep, basically. You're basically just trying to increase your suprachiasmatic nucleus of the hypothalamus. Remember, it takes things from light. It basically is like, okay, I should be sleeping right now. It's dark out, like melatonin's getting released. So you're just like increasing that amount. You can give this for insomnia. This is especially safe in the elderly. And a big note on this is it's safe in the geriatric population. It's just melatonin. It's what people buy over the counter and just take before they go to sleep. Okay, and then these guys, Phenobarbital, thiopental, and primidone. These are your barbiturates. So it has barb. This one at least has barb in the name. These are going to bind to benzo, like the GABA A receptors that benzos bind to, but it's a different allosteric site. So now we have this GABA receptor. We have a binding site for benzos, a binding site for alcohol, and a binding site for barbiturates. Okay, so there's multiple binding sites on this receptor. But now binding is going to increase channel opening duration. So benzos was how frequently they open. So they open, close, open, again, close, open. So it keeps it just frequently opens it. These guys are going to, once it opens, it's going to hold it open longer. So definitely know that benzos act in that one way and your barbiturates act in this way. Okay? What do you give them for? Again, we're still talking about sedative hypnotics, so still things to put patients to sleep and whatnot. So IV thiopental, you're going to do this for induction of anesthesia. So a lot of the times when it's like you're getting a surgery and they need to give you anesthesia, sometimes they'll give you thiopental. That'll be your anesthesia, your anesthetic. Phenobarbital, this can be for seizure treatment. Again, you can imagine hyperactivity, it can slow it down. And then primidone. Primidone is for seizures and essential tremor. And this is going to be first line for essential tremors, as well as propranolol, which is a beta blocker. All right, so this is a good one to know because it's going to be first line for something. I should have highlighted this in yellow because you will definitely get this. I had this on boards. I always get this question. And it was also in the sketchy, and I think how they explained it was really good. But before we get to that, these guys have very long durations of action. So what they'll say is, oh, there's a hangover effect. So if you've ever had surgery where they like knocked you out with anesthesia and then you wake up you feel very groggy when you wake up, that's your hangover effect. And it's because these like last so long. It's like again, alcohol, what causes you to have a hangover from alcohol is the it starts leaving those GABA receptors, and then it's just like that's kind of what's causing the hangovers when it's leaving. This is kind of the same idea. It's like it's leaving the GABA receptor. So you literally can feel like you have a hangover after you get one of these, when you take these barbiturates, or if you are getting anesthesia with the barbiturates. And then thiopental, it acts very quickly and it has a very, very short duration of action. So and a classic thing that they'll ask is like, oh, why does thiopental have a short duration of action? And everyone wants to say because of metabolism. And it's not. It has nothing to do with metabolism. It's because of redistribution. And so what sometimes they'll do is they'll show you a graph like this and either be like, which drug is the patient getting? Where is it getting redistributed? Like what part of the body is this blue line? But basically how to read this graph is you give thiopental and it's really high concentrations in the blood, right? As soon as you give it, it's really, really high. And as it starts kind of coming down, you can see it's starting to increase in the brain. Like it's starting to increase its effects on the brain. But as it's coming down, like where is it going basically? Like how is it getting, like everyone wants to be like, oh, it's getting metabolized. That's why it's going down over time. But what's really happening is it's getting redistributed. So it's going from the blood and it's now going to start leaving the blood and going into skeletal muscle and adipose tissue. So that's what this blue line is. It's going to be, and that's why it's like they're the same slopes. They're just going in opposite directions because as it's leaving the blood, it's going to redistribute into the skeletal muscle and the adipose tissue. Okay, so you can 100% get a graph like this. They can ask you whatever they want about it, but this is for thiopental, and this is going to be redistribution, not metabolism. It's leaving the blood, it's going into the skeletal muscle and the adipose tissue, and as it's doing that, it's exerting its effects in the brain. Okay. And then, so continued on that, just not enough room. Side effects of these guys is going to be hypotension. You can have cardiac respiratory depression. This is usually what causes overdoses. Severe CNS depression, also with overdoses. Remember that these act on the respiratory centers in the brain and your brainstem. So that's why you can get overdoses that you just stop breathing. Like you just kind of like stop breathing. You avoid these at all costs in the elderly. And I even have here like usually saved for the critically ill patients. Again, barbiturates, classically people can OD on barbiturates. So of course there's going to be a tolerance aspect, so they can downregulate the receptor, and you can also have physical dependence. Again, it's just like alcohol. You can have physical dependence on these, on your benzos, just like you have with alcohol. And then I did tell you to, as you start going through some pharm, you can save this for dedicated, but know which drugs are cytochrome P450 inhibitors, inducers, or I forgot the third one, inhibitors, inducers, or whatever. But there's a 30 med video where he goes through it, which is really good. But anytime I mentioned like this is an inducer, I put it here. So here's an inducer. There's a few that we're going to talk about later, which are like inhibitors, and just know those. So by saying it's an inducer, it's going to activate cytochrome P450. So what this means is other drugs that get metabolized by cytochrome P450, classically statins and warfarin, these are two of the main ones, they're going to get metabolized quicker if you're inducing cytochrome P450. So if you're metabolizing it quicker, like imagine someone's on warfarin, which is a blood thinner, and now it all of a sudden gets metabolized super quickly, they can clot. Like they can start clotting and then they can have like these clotting symptoms. So you really want to make sure like they're not on another med that is getting metabolized by cytochrome P450. Okay. But again, Dirty Med kind of goes into that in a lot of detail and it's really good. And he does a really good job, but I just kind of highlighted it wherever I could highlight it. Thank you. We love coffee. All right. All right, so those are your sedative hypnotics. All good?
I have a question. Like, do you okay, so you know how the thiopental, it's because of redistribution? I've had questions like that in UWorld. Like,
Okay.
do you, is there like a list somewhere of like which ones, like I don't know which ones are metabolized versus which ones are like redistributed.
I
Like,
think thiopental is the only one that's redistribution.
okay.
Like that I think that's why they ask it because it's like you see this graph, you know it's thiopental. Sometimes they'll make it more broad and it's just like oh barbiturates because they're just trying to be more broad, which is fine. But I'm pretty sure this is only for thiopental.
And also
Everything
like,
else mostly is metabolism.
okay, that's good to know because I think I had a UWorld question on that and I got
Yeah,
that
you'll
wrong
you'll
too.
get you'll get. I'm telling you will get a question on this.
Okay. And then also like I haven't been memorizing like the drug classes. Like what's the
Yeah, you should know the drug classes though. Like to know that because just like what I said, like this is a thiopental graph, but sometimes they'll be like, which class of drugs is this like the metabolism scheme for? Or which class of drugs does this graph represent? And you're like, oh, I know it's thiopental, but then you're like, shoot, what is thiopental? Because they'll have like, benzo, barbiturate, antipsychotic, like they'll have them all the classes listed. And you're
so
like,
like
shoot.
how like because I'm just thinking about all the psych drugs, like how do they classify these versus the benzos? Like how or do I just need to memorize like which ones are
I would
barbiturates?
just know kind of like exactly what I said. Like I would kind of know like if you see like lorazepam, oxazepam, like as soon as you see that word, you should immediately think benzodiazepine. And then all of these things you should know for your like the mechanisms, you should have this memorized per class. So this is how your benzos work. This is how your barbiturates work. And then if you're like, okay, I know that, and then they give you like thiopental as the drug, you're like, that's a barbiturate. And then in your mind, you should think of this chart like, okay, this is how barbiturates work. Because I've seen that too. And that's like why my advice is like, that's why psych pharm is difficult because it's like, you know the drug and that's great, but sometimes they want it, they're gonna ask you about the class. And then you're like, shoot. And they'll say like, and not so much with these, honestly. I'm telling you, it's more so with the antipsychotics because there's so many per class that they'll like have a bunch of like first generations listed, but then they'll have one second generation listed, and then the question will be about a second generation antipsychotic, and you're like, shoot, which one, which one of these is second generation? So, and again, that is what I think makes it difficult. But like I'm telling you, the more you do this, it'll just like I see this now, and I'm like, oh yeah, that's a benzo. Or I see like, well, phenobarbital is easy because barb's in the name, but thiopental, I'm like, yeah, that's a benzo. Or sorry, that's a barbiturate, and that's going to act through redistribution. It's just like the more you see it, it'll be better. But I have seen questions where they say like screw the drug name and they just ask about the class, and then you kind of have to know like, oh shoot, like I know the drug, like the names, I don't remember what classes they were. Okay, cool. Awesome. All right. So they ask a lot. Well, I at least got a lot about your anesthetics. Again, it's good to know which ones are IV and which ones are inhaled. Okay. So firstly, we have our propofol, etomidate, and ketamine. And I think I had oh no. Okay, so yeah, these are going to be your IV anesthetics. So I have here that propofol and etomidate are going to potentiate the chloride current through the GABA receptor complex. So it doesn't say anything about frequency, it doesn't say anything about duration. It's just imagine your GABA receptor. It has all these binding sites. So one's for alcohol, one's for benzos, one's for barbiturates. Now we have another one for your IV anesthetics. Okay, so this is all the GABA receptor. Your benzos are going to increase frequency of how frequently this is open. Your barbiturates are going to keep it open longer. These guys, alcohol, I don't think you need to really go into that, but these guys are just going to potentiate the current. So however they do that, they're just going to potentiate the current through there. That's your propofol and etomidate. Ketamine, it is an IV anesthetic, has nothing to do with the GABA receptor. It is going to inhibit NMDA receptors. Okay. So why would we give these? They're anesthetics, so it's going to be about anesthesia. But sometimes what they'll ask, and I think I might have gotten this, is induction and maintenance. So induction of anesthesia is different from maintenance of anesthesia. So if you're inducing anesthesia, you can give one shot of, IV, this one, phenobarbital. You can give IV phenobarbital. That can be an induction of anesthesia. You can even give a benzo for inducing anesthesia. All that is doing is like inducing it. You're just trying to get the patient knocked out, basically. But then for maintenance, it's like you want to maintain them being knocked out. Like you want to maintain them in anesthesia. So notice that propofol is really the only one that you can give for both induction and maintenance. And that's why if you see like when you get surgeries and stuff, propofol is like the number one, like the most common IV anesthetic because it can be given for both. You don't have to switch meds. Etomidate and ketamine can only be used for induction. Ketamine's wild. It's a wild drug. That's why people can actually abuse it. But people like I honestly feel like doctors don't really use ketamine unless it's like they have a propofol allergy or something where they need to use it for inducing anesthesia. Side effects. So propofol can cause hypotension. Etomidate can preserve cardiovascular stability, and I think again, I'm telling you, they ask so much psych drugs, but or like neuropsych drugs. I even remember a question where it was like they asked about an anesthetic, so I had the ones listed. I was like, okay, these are the three main anesthetics, and then it asked which one would you give for a patient with a sick heart, and you would give etomidate because it preserves cardiovascular stability. So it's one that's not going to mess with the heart too much. So if you have a patient that has like a weird heart, you might want to give them etomidate. And then you can switch to propofol for maintenance.
I have a quick question.
Yeah.
Like, you know how this one potentiates the chloride
Yeah.
current? Like, what does that mean? Because the other ones also affected the chloride
Right.
channel.
So like benzos are going to increase how frequently the chloride channel opens. Barbiturates are going to keep the chloride channel open longer. These guys, I know it's very like what does that mean? Potentiates. It's just potentiating the current. So it probably is honestly like it's probably honestly like increasing duration or frequency or both. It's just causing in some way, and I guess it just like sketchy you were like wherever I because these charts that I made are a combination of sketchy UWorld first aid. It's all of my notes on Pharm. So I guess it just wasn't important or it didn't come up more than knowing that it also binds through GABA receptors and it's going to increase the current through that receptor of these chloride ions. But so it might be doing both. It might be doing duration and frequency. It might just be causing, this is also acting through a complex. So it could also be like inhibiting a GABA inhibitor. You know what I mean? Like if GABA is being inhibited by another thing in the complex, it could be inhibiting that, which is going to therefore increase current through that channel. So I guess it's just not that important to know. but it's a good question. I don't know personally how these guys act. I just know it does work through GABA. But yeah, the exact mechanism, I'm not really sure. Okay. And then ketamine, like I said, ketamine is a wild, wild drug. So one of the things that can, so people can actually abuse ketamine and people can like they take it because they like these symptoms. So one of the things that it does is it causes a dissociative anesthesia. So it's kind of like it's like almost like you're awake, but you're not awake kind of thing. They call that dissociative anesthesia. So it's like your eyes are open and you have basically like a slow nystagmus, and you can imagine like you're really out of it type of thing. People like that. Um, it stimulates the cardiovascular system. So again, like if you have a patient with an issue with this heart, you want to give him etomidate. That's pretty much the only indication for etomidate because ketamine and propofol kind of can mess with the heart. And then ketamine also has unpleasant emergent symptoms. And I got a question on this before, and it was like a patient he had surgery and he woke up and he was super agitated and he just like was freaking out. He had like anxiety. He was like really paranoid. Ketamine. It was like, which drug likely was this? They probably didn't even ask that. They were like, which mechanism of the drug that this patient was likely on is it? And it's like, oh, it inhibits NMDA receptors because that's ketamine acts differently than the other two IV anesthetics. Okay, so unpleasant emergence, that's what it means. Once they're out of surgery and they're waking up out of anesthesia, it's like it's the worst thing in the world. They're very, very just like they're out of it. All right, so those are your IV anesthetics. Your inhaled anesthetics are going to be nitrous oxide, and then your ANES. So your enflurane, isoflurane, and halothane. Nitrous oxide, this is a gaseous inhaled anesthetic. This is your laughing gas. This is when you go to the dentist and they give you laughing gas, it's nitrous oxide. And then these guys are your inhaled anesthetics, but these are volatile and fluorinated. And we'll talk about why, what makes that difference, like gaseous versus volatile and fluorinated. So they act differently, obviously. So if you have a gaseous anesthetic like nitrous oxide, it's less soluble, meaning it's less soluble in the blood. And if it's less soluble in the blood, it's going, because again, think of it as like the blood is here and that's where the anesthetic is, and then the brain is up here. So you inhale it, it goes into the blood, but you need it to act in the brain. So if it's less soluble in the blood, it's going to leave the blood quicker and go to the brain and exert its effects. If you look down at the ANES, so your enflurane, isoflurane, whatever, these guys they're more soluble, so they're going to stay in the blood longer. So it's going to take longer for them to leave and go to the brain and exert its effects. Okay? So again, that's why you give laughing gas. If you've ever had laughing gas at the dentist, it straight up works in like 5 seconds. It works so quickly. And that's why it has a very fast onset. And the benefit to that is that it has a really fast recovery. Like you don't wake up and you feel groggy after you go get laughing gas at the dentist. Like it's very, very quick. They probably will ask you about the blood gas coefficient, but just think of it how I explained it. Blood and then gas. So it's kind of like up here in the brain. So since blood is first, I think of that's how it helps me remember. So if I have a low blood gas coefficient, it's going to remain in the blood less. It's lower because it's going to leave quicker and go into the brain. Versus your ANES have a higher blood gas coefficient because it's going to last in the blood longer. And then sometimes I'll show you the curves. I thought the sketchy for this one was really good because I liked the arterial tension curve. But again, it's the same idea. If it's leaving quickly out of the artery, like if it's leaving quicker, you're going to have a more steep curve. Versus these guys are lasting longer in the blood and they're trickling out of the blood. It's going to be it's going to be steeper. It's going to be less steep. It's going to be more just like it's slower kind of thing. So you can think of it like this is very fast, so that's more of like your nitrous oxide stuff versus this is a lot slower. So it's going to be more of like a less steep curve. And then some other things, they'll probably ask you these things. So MAC, your minimal alveolar concentration. It's exactly how it sounds. Minimal alveolar concentration. What is the minimum dose? Well, not the minimum dose, but minimum in this case is 50%. So what's the dose of these drugs that cause 50% of your patients to become unresponsive. So basically, like, what is the dose that I can give this patient, and they're out. So you can imagine that this is related to how potent the drug is. Because if you think about it, if you have a lower MAC, so that means you need less of a dose to knock a patient out, that's a more potent drug, right? So they'll play around with potency and MAC. So in your brain, just kind of like keep it, like understand it however works best for you, but they'll try and like play around with MAC and potency. They're just inverses of each other because one is saying like if I have less of an MAC, that means the drug is a lot more potent. It's acting a lot quicker than a drug with a higher MAC. It takes longer kind of for it to work. All in-hand anesthetics can cause respiratory depression, so all of these can. So you do have to watch, and then your side effects of your ANES. The ones I bolded, I had gotten questions on. I just couldn't remember if it was boards or the exam. They're going to increase intracranial pressure because they increase cerebral blood flow, which hopefully makes sense because they're acting on the brain. They can cause like cardiac and respiratory depression. A lot of these can. Halothane is hepatotoxic. So, and I feel like I got a question where they listed all of these anesthetics, and it was like they talked about like hepatitis, basically, like hepatitis symptoms. And it was like, which of the following drugs caused it? And it was halothane. Enflurane is nephrotoxic, and then enflurane can also induce seizures. Whoa. Okay, and then we're gonna start getting into like malignant hyperthermia, serotonin syndrome, those types of things. So, and you should know again, if something causes malignant hyperthermia, so know that these anesthetics can cause malignant hyperthermia. How do you treat it? And you treat it with dantrolene. Okay. And then just my other note is you can think of the blood gas coefficient as solubility. So if they talk about solubility of these drugs, it's kind of the same thing. So less soluble, a lower blood gas coefficient, more soluble, a higher blood gas coefficient. Okay. Next, we have our opioids. So these are kind of weird because they act in different ways and there's different indications to give them. But overall, these are going to be, when you see these, you should immediately think opiates, but there's different indications. So, for example, fentanyl and morphine, you know those are opiates. People abuse those all the time. Tramadol, loperamide, and diphenoxylate, and then codeine and dextromethorphan. So your analgesics and your agonists. So we have on here analgesics and agonists. We have antidiarrheals, and then we have antitussives. I think I meant to do it like this. I think I just didn't. I didn't space them down. So these guys are going to be your analgesics and agonists. Loperamide, diphenoxylate are your antidiarrheals, and then codeine and dextromethorphan are your antitussives. Okay. So specifically about fentanyl, morphine, and tramadol, these are going to be your your analgesics and your agonists, and they're going to agonize your opiate receptors. So they're increasing, like they're activating your opiate receptors. This is again where they're definitely going to ask this. They know that people know that fentanyl is an opiate. They want to know if you understand what opiates are doing chemically. And again, if I resend you my post boards write up, one of the things that I wrote after STEP or Comlex, I forget which one, when I talk about the neuro psych drugs, it was like they didn't care, like opiates agonize opiate receptors. They did not ask that. They asked, you have an opiate, how are the ions moving? So with like your benzos, your barbiturates, those things, it's chloride channels and it's whatever. This is now going to be potassium channels. So it's like, that's what I meant by that. Like, know how these ions are moving, know which ions are being affected by these drugs. That's like what they're interested in, honestly, is what I've noticed. So your opiate receptors, when they get activated, they're going to open potassium channels and they're going to close calcium channels. And definitely know that. Open potassium, close calcium. And then what that does is if you're closing presynaptic calcium channels, you're not releasing neurotransmitters. And that's why it's an analgesic. That's why it stops pain, because you're not getting any movement of basically any neurotransmitters.
If the potassium is open, it goes into the cell?
Hold on, I have to think about it. Potassium goes into the cell, yes. Antidiarrheals, these are also going to be like opiate receptors. They're going to bind through opiate receptors. All of these are acting through opiate receptors, but they do different things, right? So even these antidiarrheals, when they're binding to the opiate receptors in the GI tract, they're still opening your potassium channels and closing your calcium channels, but now we're in the GI tract. These can't cross the blood-brain barrier. That's why they can't get up in the brain. So they're going to bind to those, and what that's going to do is it's going to increase colonic phasic segmentation. Another way that you can see this is it increases stool transit time. So basically what it's doing is it's going to be pulling water out. It's going to be basically like pulling water out, which is going to then it's going to increase the time that it's taking the stool to travel through the colon. And that's why you can give it as an antidiarrheal. And then finally, your antitussives. So your codeine. This is like literally what's in dextromethorphan's literally in like your Mucinex, like that with the cough, Mucinex D. These are weird. They don't bind through your classic opiate receptors. They're gonna block your NMDA receptors. So now we have ketamine blocking NMDA, and now we have these antitussives blocking NMDA receptors.
What do NMDA receptors control again?
They're like they do a lot of stuff, but they're mostly just like another neurotransmitter in the brain. They're an excitatory neurotransmitter, like receptor in the brain.
And you know, for like opiate, the opiate one,
Yeah.
like I always just assumed that had to do with pain, but like this is the only time when it's not, like the antidiarrheal ones.
Yes. Yes. And you'll see too, we'll talk about like some of them, like other ones like methadone and these guys. These are also opiates, but they're like you give it for like withdrawal. So it's like you're not even trying to like block pain, you're trying to like mimic opioids. Like you're trying to get someone off of withdrawal. So you can give it for things other than pain. But a lot of the times if you're giving an opioid analgesic like after surgery or something and someone prescribes you an opiate, this is the pain symptom that it's really going for. And then other ones can act in other ways, but yeah, these antidiarrheals, these like don't really have anything to do with pain, but they do work through opiate receptors, which is really interesting. And if you understand this too, it makes sense with like sometimes they'll ask about like opiate withdrawal or they'll talk about opiate overdose. And if you understand like how the opiate receptors work, you can kind of figure out what the overdose symptoms are and the withdrawal symptoms are. Because these are normal, right? Like these are normal receptors in the body. Like the body works through opioids. It's just people started to abuse them and like so it's kind of like that's where you start getting like but like these exist for the normal physiologic functions like opioid receptors. But then, people started messing with meds and like with the overdoses and stuff. It's because it's like, yeah, you're messing with the physiology. So specifically, fentanyl, morphine, think like your post-surgery, you get prescribed an opioid. It's going to be one of these guys. These are your pain management ones. Tramadol is a mu opioid receptor agonist. And remember mu, I wrote it out because I wanted you to see mu, but remember it's that like U symbol. People always forget that. And they're like, they see mu, like they read mu opioid receptor and they're like, no, like that's not that one. And it's like, no, it's this one. So I wrote it out because I know that it can get people. These guys are antidiarrheals. These are antitussives. All right, so side effects of pretty much any of the opioids. To be honest, it's more so these analgesics. It's more so these analgesics agonists. You can't really get, I guess you can, but this is like what people classically think of when you're like, again, you overdose on an opiate. It's usually going to be fentanyl or morphine. So CNS depression, obviously. You can get respiratory depression, obviously. Meiosis. These are ones that I wanted to talk about meiosis and constipation because there's an interesting little tidbit with this that they like to ask about sometimes. So I put them both here. But constipation is the most common long-term side effect of chronic opioid use. And I put this asked on every exam because it literally is asked on every single exam. Okay, so what's the most common long-term side effect of like someone's on a chronic opiate? What's going to be their most common side effect? Constipation. And that's why you can imagine you can give opiates as an antidiarrheal. You're trying to make the patient constipated, right? Like that's the opposite of having diarrhea. So you can imagine like taking too much of it, you can cause constipation. Tolerance is very common. So tolerance is obviously that's why people can OD on this pretty easily. But and this is again, I've gotten this question before. Tolerance is not common for constipation or meiosis, meaning it doesn't matter if you take more, you're still like if you take 1 dose of fentanyl, you're still gonna have the same amount of constipation as if you take like 20 doses of fentanyl after you've experienced this tolerance effect. It's gonna be the same thing, meiosis and constipation. And remember, meiosis is like the pinpoint pupils, right? Sometimes they'll do that. They'll talk about like pinpoint pupils.
Like, does this have to do with like sympathetics and parasympathetics?
I think so. I think so, yeah. So I think like it can mess like these receptors can mess with constipation and meiosis, like these opiate receptors, but it's ultimately the sympathetic nervous system that controls that.
So like when you get all of these things, it's the opioids causing more parasympathetic activity.
Yeah, that's a good way to think about it. Yeah. But except with meiosis and constipation, because you're
Isn't
not getting
meiosis like it's still constriction though, so that could be like the parasympathetic.
um meiosis is usually, yeah, I mean it can be, you're right. Or it can just be absence of sympathetic.
Okay.
And then constipation is kind of the same thing. It's like hypersympathetic almost. So it's weird. You can think of it like that. It's just don't forget with constipation, like that's a huge effect of opiates, and this is the one that they're gonna ask. Oh, and I missed this one, biliary colic. Just anything that's like it's backing up. It's opiates are really bad for the GI tract. They're really not great for it. But what's interesting is if you have diarrhea, you can give an opiate because it'll cause backup and it'll cause constipation and stuff. And you're like, that's great. That's like what I'm trying to do. Okay. And then chronic use, you can get opiate-induced hyperalgesia, um, which is like the opposite of what you're trying to do. And then opiate withdrawal, definitely know this. And the reason I mention it is because they're not going to say, just like with alcohol withdrawal, they're not going to say patients having alcohol withdrawal. They're going to describe delirium tremens. They're going to describe the tremors. They're going to just say this. Like they're going to say patient comes in with a runny nose. They have lacrimation. They're tearing. They're yawning. They're hyperventilating, hyperthermia. They have muscle aches, diarrhea, vomiting, and then anxiety. Okay, so they're going to say this. Rhinorrhea, lacrimation, and yawning is usually like dead giveaways for opiate withdrawal because it's kind of like, again, you're not on an opioid anymore, and like these are the things that are happening now. It's kind of like the balance is out of whack now, kind of thing. So you're tearing, you're yawning, your nose is running, like all sorts of things. So this definitely no withdrawal versus your overdose kind of symptoms. They're going to be opposites of each other. Okay. Okay. And then now kind of getting into more of like these are more of like the meds, like you give this for a specific reason other than pain that we were mentioning. So like methadone, this is a long-acting opioid, and it's good to know that this is long-acting. And then we have buprenorphine, nalbuphine, and butorphanol. These are partial mu opioid receptor agonists, so partial agonists. And then buprenorphine can also be long-acting. This is important to understand, and we'll talk about why. But what these guys do is they agonize mu opioid receptors. So they're acting on that mu opioid receptor. They're opening potassium, closing calcium. But why would you give one of these guys? You give it for detox. You're trying to get a patient off fentanyl. You want to give them methadone. It's gonna basically detox them, and what this means is it's attenuating withdrawal symptoms. So patients taking fentanyl, they get off of it, they want to stop taking fentanyl, they're going to have all of these symptoms, and it's not great. So what sometimes they do is they give you methadone, and that's why there's methadone clinics. The whole point of methadone clinics is to try and get patients off fentanyl and morphine and stuff. But people can abuse methadone. Like they can abuse it because it's still acting at the opioid receptor. So sometimes people that take fentanyl and morphine, they'll go to one of those methadone clinics to get methadone to get their opioid high. So it can be abused, but the point of it is to try and help people try and get them off of opioids.
So like how does that work? So like it still is long at acting, so it's still going to cause all those things that they want, right?
Yes, it's gonna do it, but it's not gonna do it at like a higher extent, and it's going to act longer. So they don't think they need another hit of I don't really know how it works with how, people that do opioids, like I don't know if they're taking it every few hours. Like I don't really know what they're doing. But this should like keep it like they take one dose of it and they should be good for like that day type of thing.
So that's safer to like just take it
Yes.
once.
Yeah, it's
And
safer. And again, that's why they have the clinics for methadone.
got it. And then why do they have like like how does it attenuate the withdrawal symptoms?
So it's gonna still act on it's basically like you're getting a dose of opioids. That's how it's kind of like attenuating withdrawal, but it's not acting as like intensely as your opioids. So and it's going to like last you for longer. So these withdrawal side effects are really not good. So if you take like a low just think of it as like taking like a lower dose of an opioid, it's gonna kind of make these better, but you're not getting a full-blown opioid hit type of thing. And that's the point of it. It's not trying to give people like their opioid dose. It's just trying to get rid of these symptoms while they're getting off of their opioid.
Okay, that makes sense. So it's
Yeah.
lessening them, but you're still
Yes.
weaning yourself off.
Yeah. And it's weird that it's like, why would you give an opioid agonist to get someone off of opioid agonist? But
Yeah.
it's like withdrawal can be really bad. Like with alcohol withdrawal, it can kill you. Opioid withdrawal, I don't think it can kill you, but it's very unpleasant. And that's why people don't like going off. Like that's why people that start taking opioids don't want to get off of it because withdrawal is so bad. So this is kind of like a way around that. It's like, okay, we'll give you a dose of an opioid, but it's not going to be as intense. But and then it should get rid of these symptoms and then not allow them that they're still going to have a craving for like, fentanyl, but it's not going to be as it's just basically like a way around it, but people still abuse methadone and they still like, okay, well maybe let me just take like 5 doses of methadone and I'll get my hit. Because it's like that's free. Methadone's free. There's methadone clinics. So I can just get like 5 doses of it and then I'll just take it all at once and get my fentanyl dose type of thing. But for people that aren't doing that and trying to actually come off of it, it's really good because it gets rid of the withdrawal as their and that's like kind of what rehab clinics do is like when they're trying to get someone off of it, they need to get them through that withdrawal phase. And like methadone's a really good way to do it. But the other thing to know, so again, here are your overdose kind of symptoms. So these are your overdose symptoms. Here's your withdrawal symptoms. The other one you do definitely need to know is your neonatal abstinence syndrome. And again, they're not going to say this baby was born to a mother that's addicted to fentanyl. They're going to say baby was born, had diarrhea, sweating, sneezing, crying, they're tachypnic, and they're irritable. Okay? So this is basically a baby that was born addicted to opioids. Okay? And then that's why you see like these symptoms. Okay. And they'll explain it. You'll definitely probably get a question where a baby's born and having these symptoms, and you need to know it's not like RSV. Like a lot of people confuse it with like the baby was born with like a torch infection, like one of those torch infections, or the baby was born and immediately got RSV or one of those childhood like measles, rubella, something like that. This is always gonna be a newborn. That's why I think people think torch, but this should give it away that this is neonatal abstinence syndrome. Okay. Or I think actually, let me see. Yeah, I think actually this is the baby's not born addicted to fentanyl or opioids. They were in mom's belly when mom was taking opioids. And now when they're born, it was still enough time between like the birthing process was enough time that now they're experiencing withdrawal. So that's why they're mimicking the opioid withdrawal symptoms. But now we're in a baby. So it's like, it's not like your overdose symptoms because like overdosing on opioids, you should be thinking like constipation, like backing up. This is like the opposite. So we have like our rhinorrhea, you have your sneezing, you have your diarrhea, you have your sweating, crying, tachypnic, irritable. It mimics kind of this a lot. Okay. And then the other thing to know is like buprenorphine, nalbuphine, butorphanol. Sometimes they'll talk about these guys in prompts. These are your partial agonists. So a partial agonist is going to like it's going to like bind to the mu opioid receptor, but it's not going to do it as so methadone's already lower, right? It binds, it's a full binder though, it's just lower than like these guys up here. These guys are, it's like if this is the active site and like here's methadone, here's your fentanyl, morphine, these partial agonists kind of bind like this. They kind of bind like this. So it's like you're like getting partial activation of the receptor. But what's interesting is still if you have a patient, and I've actually, now that I'm thinking about it, I've seen this question before too. You have a patient addicted to opioids. They're addicted to opioids, and it's like, what drug would you want to give them to attenuate their withdrawal? It's always methadone. But they won't talk about it. They won't say like methadone. They'll say long-acting opioid. Or they'll say like partial agonist. Partial sounds great, right? You're like, okay, like if I want my patient's having withdrawal symptoms, let me give them a partial agonist. So maybe they're still getting their effects of agonism, but it's not as bad. That's 100% the wrong thing to do. You do not want to do that. And the reason why is because you can induce withdrawals with a partial agonist. Because if your patient's on a full agonist and then it's like, so like let's say they just took fentanyl, so they had these symptoms of a full agonist, and now here, take buprenorphine, which is a partial agonist. I put here like it's kind of like putting them on an antagonist because again, it's like you're not getting that effect and there's not like you're not binding this receptor enough to stimulate like lessening of these symptoms. It's just kind of like you're not doing anything. You're just kind of, it's like the dose is too low now that it's almost like it's going to make withdrawal even worse or it can precipitate withdrawal.
So with partial agonists, it's the same thing as an agonist, but it's not as intense,
Hmm.
right? And then like so with the so like is that how it works? Is like it needs to reach a threshold for you to not feel any of the side effects or like
It's either threshold or it's amount of receptors like opioid receptors that it's able to bind.
okay.
So I think your fentanyl morphines, they can bind like all. I don't think this is right how I drew it, but this is just how you can kind of think about it. I think like these guys, these partial agonists, when they bind to the receptor, they just don't bind that many receptors. So it's almost like you're doing the opposite. You're like, here's a dose of an opioid, and then it's like, no, that like didn't do anything for me, and it was like it was almost worse that you gave them a partial agonist. But yeah, I think that's all I wanted to say. I think there's another, yeah, I have another one. But you'll see like a lot of these and a lot of these act through like your mu opioid receptors. I'm pretty sure that's all we're talking about. There's a lot of opioid receptors. Um and so for example, like fentanyl and morphine, they might bind all of the opioid receptors in the whole body. Methadone and these guys only bind your mu opioid receptors. So I don't know exactly, but I know that your these guys, your fentanyls and morphines, they bind every single opioid receptor and that's in your body. And that's why you experience that such level of high. Versus methadone is only binding to those mus. So it's like it's not as intense as like your fentanyls and your morphines. It's gonna be just binding a few of them. And then
Do
these
you know
guys
what
is
the
like
differences are between, because I've gotten Anki on that and I'm like still confused on like what the differences are between those opioids. There's that one, so one that starts with a K.
oh yeah, your kappa and I think there's delta opioid. I think it's just where they are in the body.
Okay.
I don't think it's super important, but like if you're gonna get questions, you're gonna get them about the mu opioid receptors. These are the ones that are for like your pain. Like I don't believe the antidiarrheals act through mu. I can't remember off the top of my head which ones they act on, but it's the ones that are located in the GI tract. So that's why but they can't cross the blood-brain barrier anyway. Actually, I think one of these can. Now that I'm thinking about it, I actually think one of these two can cross the blood-brain barrier. Loperamide or diphenoxylate. One of them actually can. So you can actually see symptoms in the brain, like with, let's say they're kappa opioid receptors. They can bind the kappa opioid receptors in the brain. I forget. I do think Sketchy talked about it if you want to go back to your Sketchy notes. I believe one of them can cross the blood-brain barrier. But they're still specific for not mu opioid receptors. They're specific for whatever ones are located in the GI tract. And then lastly, we have these are your full overdose drugs. Like when you see someone that's overdosed, you give them a dose of naloxone. You've seen that. Like, I think even Rowan now is like I forget. There's like a big thing in Rowan right now where it's like they're giving students naloxone to like be able to administer to someone if they come across someone that is like they think OD'd. They can give naloxone or naltrexone. These are your mu opioid receptor antagonists. So these block mu opioid receptors. And the whole idea behind this is someone overdoses on opioids, they're binding all of the mu opioid receptors in the brain, all of them. So there's no movement of those neurotransmitters. Naloxone, naltrexone completely displaces. It just completely displaces the opioid. That's like how it works. So it does block, but you can give it as an overdose med, and that's why people give it for overdoses, because it displaces what's in the receptors. So I think of it better as like it's rather than like an antagonist, I think of it more of as like a displacer. Because really the only, at least with naloxone, that's pretty much the only time you ever give it is if someone is acutely overdosing on opioids. It displaces whatever is in the mu opioid receptors. Naltrexone can be given as well as like a maintenance thing. So it can sit in the opioid receptor before you take opioids. It can kind of sit here and block it. So like you take an opioid, it can't bind to it. So this is like, it helps maintain abstinence in heroin addicts. So it helps maintain that abstinence because again, even if you take heroin, it's not going to bind to its receptor. It reduces cravings for alcohol and nicotine. I think these are just things that it noticed. Doctors over time have noticed that they can give it for alcohol. Like if you're, for whatever reason. And nicotine, I don't think that it's first line for either of these. I think, again, I really think it was just like, oh yeah, we noticed that it also can do this. But I don't think they know the mechanism. And it can trigger weight loss, which is nice. Or you can give it for weight loss. Because again, opioids, you don't want to eat because your stomach feels all not great. But you can give naltrexone, and now that you're blocking the opioid receptors, you're going to start feeling better, especially if you're taking it, and then you'll start eating more. So you can give it for those weight loss symptoms. They'll trigger eating. And then if you take naltrexone, you have to measure LFTs. Again, something they noticed. And then naltrexone is very uncommonly can cause depression. So they say like if you have a patient that had a mood disorder in the past, be careful with giving naltrexone. The number one side effect of it is headache. But I have seen questions where it's like, which drug should I give this patient? Like they'll talk about like how they're a previous opioid user and now they've kind of turned to alcohol, or they'll say something like that. They've turned to smoking cigarettes. It's like, oh, naltrexone would be perfect because it's going to help with the opioid abstinence, but it's also going to reduce the cravings that they've now underwent for alcohol and nicotine. All right, cool. Okay, next we have our antiepileptics. So valproate, topiramate, lamotrigine, and levocetirizine. And no, not levocetirizine, levetiracetam. Yeah. Okay, levetiracetam. Valproate and lamotrigine are also mood stabilizers, which I talk about, and I think the next set of ones is mood stabilizers. So these are broad spectrum antiepileptics, but they're also mood stabilizers. Okay, importantly. So how these antiepileptics work is, again, kind of think about like what the class is telling you. Well, not the class. Well, yeah, the class is telling you like this is an antiepileptic. Epilepsy, you can imagine, is like just firing, right? It's just tons and tons and tons of firing. So it's going to try and calm that down, right? So how these guys work is not through chloride channels. They're going to work through sodium channels. So these are going to increase sodium channel inactivation. So you're blocking sodium channels. I always hate when it's like it increases activation. Like just say it stops them. But that's what it's saying. It's increasing when sodium channels get inactivated. It's another way of saying like they're blocking them, but it's like, yeah, it's just keep that in mind. Valproate also increases GABA levels in the CNS. And remember, GABA is inhibitory. So that's like another little thing that valproate does. So it increases sodium channel inactivation, and it also increases the amount of GABA that's present. And again, I don't think they know. They think it either increases GABA or it decreases degradation of GABA. Not sure. And then we have topiramate, which also allosterically binds to GABA A receptors. Kind of cool, right? So now we have our GABA receptor with all of its binding sites. Now we can add one for topiramate. And here's one for topiramate. So it's going to increase your sodium channel inactivation, but it's also going to bind to your GABA receptor, as well as your benzos, your barbiturates, your alcohol, all of those guys. Okay. And topiramate, by doing this, if you're binding to GABA, you're increasing the amount of GABA, right? Because again, GABA is inhibitory. We're trying to slow everything down in the brain. But notice it's a different mechanism from valproate. So valproate does not allosterically bind to the GABA A receptors. It just either increases production or decreases degradation. Topiramate is acting like benzos, acting like barbiturates, acting like alcohol. It's binding to an allosteric site on GABA receptors. So they might ask that sometimes. Like just, again, they like to ask mechanism. So mechanism, they can have this one acts through increased production of GABA. And it's going to have, valproate is listed, topiramate's listed, and then all the ones that allosterically bind. The answer to that would be valproate, because that's the only one that increases GABA, but it's not allosterically binding to GABA receptors. So that's kind of like how they'll ask like mechanism, but that's why it's good to know drugs still. It's good to know the names of these drugs. Okay, so why would you give this? They're antiepileptics, so think seizures. So with all of these seizures that I have listed, just remember too that they probably won't say patient is having a focal seizure. They're gonna describe a focal seizure and expect you to know like this is a focal seizure. Okay, same thing, generalized seizure. Juvenile myoclonic, myoclonic seizure. Like they're gonna describe it and you have to know like the type of seizure they're describing. This is classic with like absence seizures with ethosuximide. They will never say patient's having an absence seizure. They're just going to describe an absence seizure and you have to know it. I actually think on this exam, second year, so like when I took this exam, they made it really tricky. Like because when you think absence seizures, you're thinking of like a child in school, right? Like a little kid. They described on this exam, they described a little kid. And I think everyone immediately was like, oh, this is an absence seizure. And then it asks which of the following is the mechanism of the drug you would give, like the most common drug for it. And everyone picked the mechanism for ethosuximide. But I think the answer was it wasn't an absence seizure because the way they described it was like a generalized seizure or something else. So just keep that in mind. I think everyone got that, almost everyone got that question wrong. I definitely got that wrong. I don't even remember the question, but I'm like, oh, I definitely picked absence seizure for that. So just keep in mind, they're going to describe the seizure. They're not going to say what type of seizure it is. So just really go through it. And when you see a child, they can be tricking you. But when they describe it, you're like, oh, it's not an absence. It's like generalized or it's like tonic-clonic or something like that. And then always know the first lines. I actually think in first aid, there's a list of the first lines for all of the seizures. I don't know if you know what I'm talking about, but it's like a chart and they have little check marks. It's so know that because same thing, they'll ask most common drug for this type of seizure, what's its mechanism? Okay, so remember valproate and lamotrigine are also mood stabilizers, so I have their mood stabilizing effect here as well. So as valproate, you can give valproate for absence seizures. It's not first line, we just talked about ethosuximide is, but you can also give it to the patient if like this patient that's having absence seizures is also having tonic-clonic seizures. Okay? So that's usually why you would give valproate like over ethosuximide for an absence seizure. And then you can give it as a mood stabilizer for bipolar disorder. And I put here for bipolar, a lot of these it's also used as a mood stabilizer. A lot of the times it's for bipolar, but sometimes it'll say like, oh, you only give it when they're going through their acute mania, or it's acute mania and maintenance.
See, I didn't understand that. Like when I had a question on this yesterday, and they said acute mania and maintenance, but isn't maintenance given all the time, even when you don't have acute mania?
Yeah. Yep. So if they're having let's say they're on lithium, like you have your patient on lithium for bipolar, that's a really good maintenance. That's a really good maintenance drug for bipolar. And now let's say they start having SIADH, like they're starting to have those symptoms that lithium can cause, or they become pregnant. Lithium's a teratogen. You don't want to give them lithium. So you can switch them to one of these other ones that it says you can give for acute mania and maintenance. So you can give if they're pregnant, you can't give valproate, but you can give oh no, it's not. Oh yeah. So you can give lamotrigine, for example, if you want to switch them from lithium or valproate. That's actually a really good example. Patient becomes pregnant. They can't be on lithium or valproate because they're both teratogens. So you can switch them to lamotrigine. That can be their new maintenance med. But now let's say they have like an acute manic episode. Again, still can't give them valproate or lithium, but you can give them another mood stabilizer for acute mania.
So, like, let's say with valproate, if
Yeah.
they're having a manic episode, then can you give it short term,
Hmm.
even though also, okay,
Yep, you can definitely give them that, even if they're already on a maintenance med or even if they're on valproate. You can still give them another dose. That can be like your acute manic dose type of thing.
okay.
Yeah, I'm glad you got a question on that because yeah, they will ask like which one can you give for like these acute manic episodes versus like just maintenance of bipolar, which again usually is going to be lithium, but there can be indications where you'd want to switch them to something else. You can also give it for migraine prophylaxis. Usually don't, but you can. Lamotrigine, you can also give for absence seizures, not first line, and it's not as effective as valproate. When I see things like that, it usually tells me like you can give it if it's like something is going like again, the patient's on valproate and they become pregnant. They can't be on valproate. So you can give them lamotrigine even though, so you can do things like that. But I would definitely know your first lines for all of these seizures and the descriptions of the seizures. I think that's how they're gonna, just at least on your exam for sure, that's how they're gonna ask the questions. And then for lamotrigine, like I just said, you can give it for bipolar, but you can't give it for the acute manic episodes. You can only give it for maintenance. So again, this would be a really good one if like the patient becomes pregnant and you're trying to switch them to a non-teratogen mood stabilizer. You can put them on lamotrigine. And then topiramate, it's kind of like with naltrexone. They kind of just noticed it also helps with those alcohol cravings. So it's kind of the same thing. It's not FDA approved, but it seems to help exactly like naltrexone. And usually when that happens, when it's not FDA approved, it's because they have no idea why. They're like, I don't know why. It's just something we've noticed. But just something interesting. I don't think they'll ask that. Many antiepileptics are metabolized by CYP450, so it's just something to keep in mind. And I have here like your inhibitors and your inducers. For your exam, I don't think it's that important, but definitely for STEP, you should make a chart of like kind of what I was mentioning, like what all of the meds metabolized by CYP450, your inhibitors, your inducers, and then just kind of keep that in mind. Dirty Med has a really good video on it, so you can even just watch that Dirty Med video. Every teratogen in the book you should know, especially for Comlex, you're almost guaranteed a question on a teratogen, like every teratogen on Comlex. So I put my little teratogen tarantula here as a reminder. So valproate is teratogenic, and what does it cause? It can cause neural tube defects. So the number one it causes is spina bifida. Valproate is also a CYP450 inhibitor. So remember inhibitors, if they're on something like warfarin, which also gets metabolized by CYP450, and then you put them on valproate, now the warfarin is going to get metabolized. It's not going to get metabolized. So if it's not getting, now the patient can technically be on too much warfarin and now they can bleed out. So that's your inhibitors. That's why CYP450 inhibitors are not great, because it's like you're blocking metabolism of another drug that gets metabolized by CYP450. So it's just something to keep in mind. A lot of the time, like in vignettes when they're like patients on this med, this med, this med, this med, and this med. It's like when you start like trying to pay attention to the CYP450 inhibitors, inducers, it's like I would make like little checks. I'd be like, okay, this is an inducer, this is an inhibitor, or like warfarin, this is metabolized by CYP450. So like if they're like, oh, I'm gonna put them on valproate, I'm gonna be like, can't put them on valproate because then they'll bleed out with their warfarin, or you need to like decrease their warfarin dose before you do that. Just something to keep in mind about. And then symptoms, so side effects. So weird, like just weird stuff, GI distress, increased appetite. These are things I don't think they'll ask about, but I think it'll help you if you're trying to figure out which drug they're on. Side effects a lot of the times are good for trying to figure out which medication they're on. It's like you put this patient on this drug, and that now they're having GI distress, they're gaining weight, they're losing their hair, they have some hepatitis symptoms. That can help you be like, oh, this sounds like valproate because they were started on this med for like a seizure. Yeah, but the one that's, I think if they were to ask about, it would be this one because this one can be fatal. So hepatotoxicity, it's kind of the same as like your halothane with you have to monitor LFTs because you don't want them to like have hepatitis to the point where they can die from their hepatitis. Topiramate is an inducer. So again, when we talked about inducers last time, the inducer will make CYP450 work faster. So now if the patient's like on warfarin, for example, it'll get metabolized quicker. So now the patient has like they might start clotting too quickly. Cause so if you put the patient on like topiramate, which is an inducer, and they're on warfarin, you would want to increase the warfarin dose if it's like necessary that they're on topiramate. Versus an inhibitor, you'd want to decrease the warfarin dose. Here's some of these things. Some of it's symptoms with topiramate. It's like it kind of messes with the brain a little bit. So somnolence, fatigue, confusion, cognitive slowing. So sometimes they talk about this as like cognitive clouding. They just feel very cloudy. Weight loss, kidney stones, and then myopia. So since it can cause myopia, it can trigger acute angle closure glaucoma. Okay, which I don't know if you've gotten to that yet with neuro. But at least I know Dr. White talked about that last year. But he kind of goes into like glaucoma and like what it is and whatnot. But it can trigger that because it can trigger myopia. Again, not sure why, but if they're talking about like brain symptoms and like the eye symptoms, that's more of a topiramate kind of aspect versus like valproate. And then lamotrigine commonly can cause a rash. They call it a benign rash because it's like you just get a rash, it's fine. But sometimes it can cause SJS or TEN. And this is another thing I would also make a list. And every time you see a medication, usually it's antibiotics, but if you see a medication that can cause Stevens-Johnson syndrome or what is this? It's like epidermal necrolysis. I would make a list of those drugs because that's really easy to spot in a vignette. Like the skin starts falling off the face, starts peeling off. Like you're like, that's SJS. So it's like, it can only be these drugs. So it's because that's, again, really easy to see in a vignette. So lamotrigine can do that. I feel like I've gotten a lamotrigine question about SJS. It can also make you cross-eyed, and then levotiroxetam, I have no idea how to pronounce that, can cause somnolence. But again, it's more so just to help you like differentiate between these antiepileptics, these side effects. All right. Next, we have carbamazepine, phenytoin, gabapentin, tiagabine, and then vigabatrin. All right. So these are your narrow spectrum antiepileptics. And usually when it's like, okay, these are narrow spectrum, these are broad spectrum, right? It's kind of like antibiotics. Broad spectrum antiepileptics, you can give them for like any, the focal seizures, generalized seizures, like you can give them for that. Usually your narrow spectrum, it's like each one has an indication. Like you should, like each one is going to be something a little different because it's, again, same with antibiotics. Their narrow spectrum is like, oh, it's like this is an anti-pseudomonal. Like this is a narrow spectrum anti-pseudomonal. So it's kind of like the same thing here. Carbamazepine, also a mood stabilizer. All right, so, and again, since they're narrow spectrum, they have the ability to all have different mechanisms. Sometimes they don't, sometimes they do. So I broke it down, each one. So carbamazepine is going to increase sodium channel inactivation, just like your broad spectrums. Phenytoin, same thing, increases sodium channel inactivation, just like your broad spectrums. Gabapentin is going to be a little different. It's going to block your voltage-gated calcium channels. And you'll notice whenever we're talking about like one of these neuro drugs and it's blocking calcium channels, just like your opioids, you're getting like an analgesic effect. So you would give a medication that does that for something like pain. And you'll see, again, that's why gabapentin, one of the indications is for like various types of pain because it's blocking these calcium channels, just like your opioids. Tiagabin, or whatever pronounces this is going to inhibit GABA reuptake. So it's kind of like an SSRI. It's blocking reuptake. So it's going to make GABA last longer type of thing. It's going to make it exert its effects longer. So we're increasing inhibition. And then vigabatrin is going to irreversibly inhibit GABA transaminase, which again it's going to decrease GABA degradation. So these two are kind of acting through GABA, but different mechanisms, just like these guys. This valproate might do this. It might, also decrease GABA degradation, or it might like decrease reuptake of GABA. Again, it's not super important to know clearly. Topiramate, it's good to know that it's binding allosterically. These two are not binding allosterically on your GABA receptor. They're going to inhibit reuptake or they're going to decrease degradation.
I have a quick question carb with
Carbamazepine.
yeah, the first two,
Mhm.
like if they act in the same way, why can't they be given for the broad spectrum?
That's a good question. I don't know. I actually don't know. I'm wondering if it's just like they can, but usually you give it first line for these conditions. They just found that it works better for these. Just like, because some of the, like, for example, the antibiotics is a good way. Like, there's a lot of penicillins, but it's like, and penicillin in general is a very broad spectrum antibiotic, but there are some, like cephalosporins, for example, those are more of like a narrow spectrum class of your penicillin. So they act the same way as penicillins, but they just found that they work better for certain things. And that's why you would give like a cephalosporin versus a penicillin for like certain bugs, because they just notice it works better even though they're acting the same way. But yeah, I don't know exactly why. They are doing the same things, but it's probably one of those things. It's like, oh, carbamazepine is fantastic for trigeminal neuralgia. So we're only going to give that to patients that have trigeminal neuralgia versus like one of these seizure types. Okay, and then in general, these are given for focal seizures. But notice you can give one of the broad spectrums for focal seizures. But again, it's going to be like that's why it's like I separated them in like how when you would give it because it's like yeah, this sounds very broad, but it's these are narrow spectrum. But regardless, you can also give it for a generalized tonic-clonic. And I put this in I guess caps and highlighted it, so I guess this was really important. So it's really important to understand that you can't give these to patients with other types of generalized seizures. Oh, I see. So if a patient just has like a regular generalized seizure, you can't give it to a patient that also has like a generalized tonic-clonic seizure. It can exacerbate the symptoms of the like I guess the myoclonus or whatever's happening with the tonic-clonic seizures. All right. So carbamazepine, remember, it's also a mood stabilizer, but it's an antiepileptic. It's going to be first line. So here's a good one for first line to like note down for trigeminal neuralgia. You can also give it for acute mania and maintenance for bipolar. Phenytoin, you can give it for status epilepticus. Usually is treated acutely with IV benzos, but phenytoin can be given for maintenance. And then also remember that phenobarbital, one of those barbiturates, can be given for refractory seizures. So this doesn't seem like it has a first line indication, but it's like one of those things that it's like, okay, let's switch them or like let's try them on this. Gabapentin, again, since it has that calcium blocking effect, think pain. So you're going to give this for pain. Um, so neuropathic pain, diabetic neuropathy that's causing pain, so painful, fibromyalgia, which is just pain everywhere, post-herpetic neuralgia. My grandfather has this. It's and he's on gabapentin, and he really likes it for it. And post-herpetic neuralgia is basically like when you have shingles, but you don't treat it. Shingles can kind of, you know how like shingles comes back, like it has like that, it comes back. It's basically just a varicella zoster that comes to the surface and it causes that painful rash. It can post-herpetic neuralgia is like if you don't treat it, it can like burn. It can literally like burn off your nerves. And that's why it causes like such like a burning type of pain. You can give it for ataxia, but again, I think pain with gabapentin. And then many anti-epileptic drugs, like I said, CYP450. Carbamazepine and phenytoin are teratogens. So what can carbamazepine cause? It's going to cause neural tube defects, so it can cause spina bifida. Phenytoin can cause cleft palate. Again, know all of your teratogens and what they cause. Carbamazepine and phenytoin can cause drug-induced lupus. So remember, drug-induced lupus is lupus symptoms after starting a medication. But do you remember what the antibody is that diagnoses drug-induced lupus?
The dsDNA.
No, that's your normal lupus. Remember drug-induced?
Is it like the histone one?
Yeah, antihistone. Awesome. So it's going to be exactly the symptoms of lupus, but you check it for all the lupus antibodies. So like, anti-Smith, anti-double-stranded DNA, and ANA, anti-nuclear, anti-whatever, chromatin, whatever, all of those lupus, all of them are negative. But then you test them for antihistone and it's positive. And you're like, this is a drug-induced lupus. So they're probably on carbamazepine or phenytoin if they mention an antiepileptic. So side effects, these are, again, we have some inducers here. So carbamazepine is an inducer, phenytoin is also an inducer. So remember, with carbon inducers, it's going to degrade your other CYP450 meds. So if you're on warfarin, you want to put them on a higher dose of warfarin with your inducers. Here's some things it can cause: ataxia, diplopia, SIADH, DRESS syndrome. This is like your eosinophilic, just like it's just like you take the medication and they just get red. It's like they're having like an allergic reaction to something. It's completely, which it basically is. It's basically like a widespread allergic reaction, but it's not. There's no anaphylaxis. It's just like the eosinophils are just like completely degranulating, and it's causing symptoms of like massive amounts of histamine release. So that's DRESS syndrome. This can cause SJS. So again, make your little list with SJS. And something interesting is it's a specific allele for SJS, and it's almost exclusively in Asians, which again, super interesting. So if you have an Asian patient that has SJS, they're probably on carbamazepine or phenytoin, because it's the same thing here, which I just thought is something interesting. So phenytoin, same thing. It can cause ataxia and diplopia, just like carbamazepine, but it causes folate deficiency. So here's a good way to kind of differentiate the two automatically. And again, if you have folate deficiency, remember your megaloblastic anemia. So they're going to have a high MCV. They're going to have your hypersegmented neutrophils, things like that. Gingival hyperplasia, so it can cause like the gums to kind of like get all weird. Hirsutism, decreased bone density. Again, it's just weird symptoms, but it's just a way to kind of differentiate between the two antiepileptics, because you're going to know that they're going to be on an antiepileptic, but then reading the symptoms or the side effects, it's like, okay, I know which one they're on. And also SJS. Okay, and then lastly, ethosuximide. Definitely know your mechanism. I get this question all the time. It blocks your T-type calcium channels in the thalamus. But these are your T-type calcium channels, and specifically we're in the thalamus. So these are not just like generalized calcium channels. That's why it's not really pain. It's not really pain here. It's more so like for your absence seizures. So these are your absence. Again, they're going to ask mechanism for the first line. So these are first line. And then again, valproate can be used. And the only really reason you would give valproate is if the patient has a history of tonic-clonic. So remember on the last slide, I have that. It's like you can give it, now where'd I put it? Right here. You can give it if they also have a history of tonic-clonic. That's the only reason you would give valproate over ethosuximide. And then absence seizures, again, they're not going to say patient has absence seizures. Usually it's in children, but remember, don't get got like we all did like 2 years ago whenever we took it. Because if you see a child, they don't have to be having an absence seizure. They can be having another type of seizure. But these are your sudden momentary lapses in awareness, staring, blinking, clonic jerks. And this is like usually the child is like sitting in school. The classic vignette is like they're sitting in school and they're just staring out the window. That can be a seizure, an absence seizure. Another thing that they can do to kind of help is they can talk about like these EEG readings, which is the 3 Hertz spike wave complexes. Sometimes they'll do that. They'll explain an absence seizure, and then they'll say, like, what do you think you're going to see on an EEG? And it's like these 3 Hertz spike wave complexes superimposed on normal background activity. And then side effects, GI distress, lethargy, and fatigue, but not as important. All right. Mood stabilizers. So lithium is a mood stabilizer. It's a small cation. So it's really weird. It's not like what it's basically doing is just a small cation, but what it's doing is it's blocking signal transduction pathways. So again, signal transduction, they love your G protein receptors. So just remember that. So one of the things that it can block is IP3, which remember is a second messenger in the GQ pathway. Or it can also just block other protein kinase pathways. They might not be your G proteins, but just other kinase pathways in like signal transduction pathways. This is usually your first line for bipolar disorder, and it's acute mania and maintenance. You can also give it for depression. Again, it's a mood stabilizer. So you can kind of play around with these mood stabilizers for like various types of mood issues. Lithium, very, very narrow therapeutic index. But why they really like giving this is it's one of the only drugs that's been proven to lower suicidality, which I think is really cool. Like it has been proved to lower suicidality. Kind of cool. It's renally excreted, and I bolded this because this would be like another indication to get the patient off of lithium. Let's say they start having, kidney issues or they start having kidney failure, take them off lithium because it's not getting metabolized at all. It's a teratogen. Again, patient becomes pregnant, get them off lithium. Definitely know what it causes in what the teratogen. I mean, know the teratogen, like what the teratogens cause in all of them, but lithium, they love to ask this because it's like just a cool one, I think. So remember Epstein's anomaly? So Epstein's anomaly is when it's like atrialization of the right ventricle. So remember with the heart, we have our septum here. So this is normal. In Epstein's anomaly, it looks like this. It's like the right atrium, it's like this. So like the right ventricle, which should be this whole thing here. I just realized I can change colors. Isn't that cool? So the whole right ventricle, which should be this, is now only this. So that's what they mean by like atrialization of the right ventricle. It's like more atria than ventricle, which is not good because now it's like you can't pump out all the blood into the pulmonary artery that you should be. So that's not good, but that's called Epstein's anomaly. They always ask that. Weird side effects, but the main one is going to be, oh, I said SIADH earlier. My bad. It's nephrogenic diabetes insipidus. So remember nephrogenic, how do you treat this? Thiazides. So you give a thiazide for that. But it can cause a bunch of stuff. So GI symptoms, neurologic symptoms, hypothyroid. And the reason it causes all these weird side effects is because of its low therapeutic index. It has such a low therapeutic index that like you can imagine that this drug is like acting everywhere. So if you even mess up the dose a little bit, it can cause all sorts of issues just everywhere in the body. And then contraindications. What's a contraindication? When would you not give lithium? Again, these are good examples of patient has bipolar, we need to put them on a med. Again, usually they won't ask you which med you put them on, but sometimes what they'll do is like, what's an indication to not put the patient on lithium? So 1, they have kidney failure. 2, they're pregnant. Or 3, one of these guys. They're also on a thiazide. They're also on chronic NSAIDs. Or 4, they're also on an ACE inhibitor. These would also be contraindications to not put the patient on lithium. And remember, so if you're like, well, why can't you put them with, an NSAID or an ACE inhibitor? It's like both NSAIDs and ACE inhibitors decrease clearance of lithium because they're decreasing GFR. So since they're decreasing GFR, this is renally excreted. You can't put them on lithium. And since lithium has such a narrow therapeutic index, like it only works between like these two levels. If you mess with lithium, now it's going to be up here, like up in the body, and it can cause all of these things. And it can also just like not be good.
Why are thiazide diuretics given again for SIADH? I forgot.
For nephrogenic diabetes insipidus. It's a really good physiology question. I actually love explaining it to people for the first time because they're like, whoa. So remember thiazides, how do thiazides work? Where do they work in the nephron?
The distal.
Mm-hmm. And do you remember what they do?
Do they spare the calcium?
No, those are your loops.
I forgot.
It's okay. So they're going to block those sodium channels, the ENaCs. Remember ENaC? So epithelial, NAC. So they actually block ENaCs in the distal tubule. So they're going to stop this. So now the distal tubule is like, hey, I'm not reabsorbing any salt. And remember, when salt gets reabsorbed, water follows it. So what happens is, remember tubuloglomerular feedback?
Mm-hmm.
Very briefly, or like you're like, oh yeah, somewhere in there. What happens is, remember how the nephron usually is situated. Here's like the Bowman's capsule, proximal, and then it's like your loop, and then your distal. But remember, the distal is really close. Like how the nephron is usually drawn is not how it's actually sitting. The distal tubule is right next to Bowman's capsule, like literally right here. So what happens is we get this feedback. The distal tubule talks to like the afferent, efferent tubules and is like, hey, I'm not getting that much water. Like I'm not reabsorbing as much water as I should. So what happens is it literally forces the proximal tubule, because now it's saying like, hey, I'm not getting enough salt reabsorption, so I'm not getting enough water that I'm reabsorbing that I should. It's basically like tricking the nephron into reabsorbing water earlier. So now we're going to start reabsorbing water in the proximal tubule because we're blocking sodium reabsorption down in the distal tubule. So we're increasing it more. So that's like, it's kind of like a good physiology way of like tricking the body into reabsorbing water earlier by giving, a thiazide for nephrogenic DI. It's
Okay,
cool.
thank you.
Yeah, no problem.
I forgot. I was just like,
No, you're good. That's like a, it's like, that was so long ago. And then remember also thiazides increase calcium. They actually increase calcium reabsorption. So you can give it for like osteoporosis. You can give it for if someone has like calcium kidney stones, you can give them a thiazide because it'll force calcium out of the urine, like out of what's going to the urine and force it into the blood. So that would be a good one to give for like a calcium kidney stone. It's really interesting. But yeah, so thiazides for nephrogenic DI, you're messing with the physiology of the nephron to force it to reabsorb water earlier in the proximal tubule versus where it usually reabsorbs all of its water, which is more of like the convoluted tubule at the very, very end. I love when the body is smart. I love it. Okay, and then here are, I just wanted to put these on here to remind you like, here's the antiepileptics, which are also mood stabilizers that we've talked about. And then there's some that we're going to be talking about coming up. So like haloperidol, quietapine, these are your antipsychotics. These are antipsychotics, which are also mood stabilizers. So these are coming up, I think, next. No, we're doing antidepressants next. But yeah, so just remember, like we're going to be talking about these in the future. They can also be given as mood stabilizers. Do you want me to keep going because it's 12? Like, do you want to finish these?
um, I'm good to finish them, but like, how much more do you think we have? Like,
We have antidepressants and then we have their antipsychotics.
I
With
think we can
anti
get through it. I'm
Okay.
like focused, so.
All right, let's do it. I think we should finish. And then you can do all the questions after. And I even with the questions, I put little, like if I thought it warranted a little bit more of a description, I did like a few slides on like describing it after. Okay. Antidepressants, I'm not gonna lie, these are my absolute least favorite of the drugs. And mostly it's because of how many names there are. I even like the antipsychotics more than these because there's so many different classes of of antidepressants, which you'll see. So the ones that I bolded, I personally think you should know all of them just because I don't like leaving it up to chance that you're not going to get a drug name. But if like you're in a bind and you're like, I can't memorize all of these drug names, like there's just way too much. For the antidepressants and the antipsychotics, I bolded the ones that are you need to know these. Okay. But I still think you should like citalopram comes up all the time, sertraline comes up all the time. It's just like if I had to pick some, I would pick paroxetine and fluoxetine as like the main ones to know. Okay? So that's what I did with the bolding, but I still think it would and again, these are ones that like since this is a combination of like sketchy, U World, first aid, like these came up somewhere. Like these drug names came up when I was doing questions. So that's why I added it. Even if they're not like in sketchy, I added it because like I got a question on it or something like that. Okay. All right. So these are your SSRIs. So your selective serotonin reuptake inhibitors. So paroxetine, fluoxetine are the main ones, but also sertraline, citalopram are also really good ones. Don't get confused with the endings because they can kind of sound like, your benzos. So just remember that these are SSRIs. So what they do is they block reuptake of serotonin. So just like those ones that were acting earlier that were blocking reuptake of GABA, it's making GABA last longer. Same thing here. We're making serotonin last longer. So we're blocking its reuptake back into the presynaptic neuron. But a really big important note is SSRIs and SNRIs, so selective serotonin and norepinephrine reuptake inhibitors. These are going to take a very long time to work. That's like a very important thing to understand is they can take up to 2 months to work. So you do not want to get, if someone's having like an acute depressive episode and you are worried about like suicidality or something like that, you do not want to put them on an SSRI because it'll take too long to kick in. Okay. So SSRIs and SNRIs, these are going to be first line for depression, generalized anxiety disorder, panic disorder, PTSD. So every other drug that you can imagine that treats one of these things are going to be second line to your SSRIs and SNRIs. SSRIs only can also be given for OCD. And then it's going to also be given, they can also be given for bulimia, not anorexia, so bulimia. And then you can also give it for social anxiety disorder. SNRIs can also be given for diabetic neuropathy, chronic pain, and fibromyalgia. I think I got a question on like patient had fibromyalgia, but also had like these depressive symptoms, SNRI versus an SSRI. Okay, so this would be like they'll have multiple drugs listed, and it was like, okay, you give the SNRIs for more of these pain symptoms in addition to the depression versus like, more of like the anxiety type of disorders like OCD, social anxiety, bulimia. Okay. And then side effects are going to be for SSRIs, SIADH, so they can cause hyponatremia, because remember, SIADH can cause hyponatremia. I think I put this like this because I got a question where the patient was having hyponatremia. And it's like, they didn't explain SIADH, but you're like, oh, I forgot, like SSRIs can cause SIADH, which can cause hyponatremia. Sexual dysfunction. So this is the number one reason why people don't like going on SSRIs. Like they do not like going on it because it can cause sexual dysfunction. Like they are not having like good experiences. So a lot of the times like they'll talk about like a 3-year-old that they don't want to put on an SSRI because of this side effect. So it would be like, what's like another way, like what's another drug that we could give to this patient? It can also cause weight gain and drowsiness. So again, sexual dysfunction and weight gain, again, why people don't like going on SSRIs. They just don't like it. It's a really good med, but it has these really bad side effects. And you'll see that's why there's these other antidepressants that are going to come up on the future slides. So SSRIs and SNRIs can cause serotonin syndrome because both can inhibit serotonin reuptake. So it increases serotonin. And again, remember with serotonin syndrome, they're not going to say patient has serotonin syndrome. They're going to describe it. So hyperthermia, hypertension, neuromuscular hyperactivity. And this is only if it's combined with other drugs that increase serotonin or 5-HT. So TCAs do this, MAO inhibitors do this. So just keep an eye out for that. Like serotonin syndrome. We talked about malignant hyperthermia with the inhaled anesthetics. Now we have serotonin syndrome. Malignant hyperthermia, you treat with dantrolene. Serotonin syndrome, you're going to treat with cyproheptadine. Okay? And then if you can actually withdraw from SSRI. So if you don't taper off of it, you just stop taking it, you can have flu-like symptoms, which is interesting. And then this is the same thing down here, but it's a lot less common to have serotonin syndrome in an SNRI, because remember, SNRIs also inhibit norepinephrine, not only serotonin. But a side effect for this can also be hypertension. And then we're going to see with the antipsychotics, a lot of the times so malignant hyperthermia, you can kind of piece out because it's like, that is for an inhaled anesthetic. It's kind of obvious that it's malignant hyperthermia when they start this inhaled anesthetic. For these guys, serotonin syndrome, we're going to talk about neuroleptic malignant syndrome. It's like you start them, they don't say like it's an anesthetic. It's like you start them on a drug kind of thing. And now it's like they describe serotonin syndrome or neuroleptic malignant syndrome, and you're seeing that it's going to be you have to kind of piece out the symptoms so you can figure out which antidote to give them. Half hour. Yeah. Okay.
Wait, when do you get the NMS one again?
You get it with your antipsychotics. So we're going to talk about it with their antipsychotics. All right. But the reason they like to compare the two is because NMS, you have the exact same symptoms as serotonin syndrome. So like hyperthermia, hypertension, neuromuscular hyperactivity, you have all these symptoms, but then you additionally have hyporeflexity. So it's like everything's down, versus serotonin syndrome, this is hyperreflexity and clonus and stuff like that. And they have two different antidotes. So serotonin syndrome you treat with cyproheptadine, and neuroleptic malignant syndrome is a different antidote. All right. So your TCAs, I again highlighted the ones that I think are most important to know. These aren't as bad. They end in most of them end in pramine. A lot of them do. But there also is the trip. You can see trip in the name because that's it's a tricyclic antidepressant. I think of tri. So that's in there. So these are your tricyclics. These are going to inhibit presynaptic uptake of serotonin and norepinephrine. So they kind of act exactly how SSRIs and SNRIs, well, actually they act pretty much like SNRIs, how they work. But in addition, how you know you're on a TCA is there's the anti-ham symptoms. And I don't know if you've heard this term before, but sometimes like when people talk about meds, they're like, oh, that's an anti-ham drug. And anti-ham is it also, so anti, it blocks histamine receptors, alpha 1 receptors, and muscarinic receptors. So there's a few drugs coming up, some of the antipsychotics as well, which are anti-hams. And that's what it means. And I even made a list before my exam. I made a list of all the drugs that are also anti-hams. So TCAs are one of them. And if you know that they're anti-hams and you know what blocking these receptors would do, you can piece out the symptoms again or the side effects. So if you're blocking histamine, you're going to get, do I even put it on here? You can get like sedation, like you're going to feel really tired. Like H1 receptors are, you get really, really tired with those. Alpha 1s, you can get orthostatic hypotension. So blocking alpha 1s, you can get orthostatic hypotension. Muscarinic, it's going to be kind of like reviewing like what does blocking muscarinic acetylcholine receptors do? And it's going to be the opposite of like what activating your muscarinic receptors do. So like you'll see dry mouth, constipation, blurred vision, urinary retention, things like that. It's all from that anti-muscarinic effect. These also can block cardiac fast sodium channels so they can widen QRS. So you can imagine that it can widen QRS, but you can, there's like a cardiac aspect to TCAs versus like your SSRIs and your SNRIs, which don't really have any cardiac effects at all. Like Torsade, where is it? Yeah, widening of QRS, you can induce Torsade. So just remember, like I actually think I got this question on the exam. It was like they talked about an antidepressant that inhibited serotonin and norepinephrine, and it was like, but the patient went into Torsade, and you're like, it's TCA. Like, TCA. And then nortriptyline and desipramine, these are secondary amines. So we have tricyclic. These are tricyclic amines. Basically, these are secondary amines, just these two. So you see less effects. So let's say you put the patient on like amitriptyline and they're having really, really bad side effects. You can put them on one of these guys to lessen the side effects. What you give it for, treatment-resistant depression. A lot of the times you'll see like treatment-resistant depression is an indication for a lot of these antidepressants because first line for depression is your SSRI, SNRI. So let's say the patient isn't responding well to an SSRI or an SNRI, you would give a drug for one of these treatment-resistant depression type things. Diabetic neuropathy, I mean, you can imagine it's going to be similar to like your SSRIs, SNRIs. You can give it for that. You can give it for chronic pain, migraine prophylaxis. Clomipramine can also be given for OCD, but again, SSRIs are first line. Adverse effects, again, it's almost like a mix of like your SSRIs and your SNRIs. So like sexual dysfunction and seizures, serotonin syndrome can be a side effect. Since we have the anti-ham symptoms, antihistamine effects can be sedation, increased appetite and weight gain. That's your H. Your A, you could get orthostatic hypotension because you're blocking alpha 1 receptors. And then your M in anti-ham is you can get anticholinergic effects. So everything that blocking muscarinic receptors you would expect can happen. Anytime you have something that blocks H1 histamine receptors, it's going to be contraindicated in elderly patients. So this is an example of one of those. So you don't want to give, mostly for the antihistamine effects, but also the anticholinergic, but you would not give like a TCA, for example, to an elderly person. They're very sensitive to antihistamines, especially the H1 antihistamines. And then like we talked about, it can widen QRS, which can induce Torsade. Know the antidote. So how do you treat Torsade? You give sodium bicarb. And then I say here, tricyclic, think of the 3 C's, cardiac, coma, convulsion. So these are going to be the three main side effects of basically taking a tricyclic. So if you see a patient with like cardiac effects, that's your Torsade. Going into a coma, that's not really a coma, but it's like the antihistamine effects. And then having convulsions, that's like your seizure effect. Okay, so those are TCAs. Next, your monoamine oxidase inhibitors. So phenylzine, isocarboxazid, tranylcylpropamine, that's these, and then selegiline is this. So These guys, your monoamine oxidase inhibitors, they're going to inhibit monoamine oxidase. Monoamine oxidase. Monoamine oxidase normally breaks down serotonin, norepinephrine, and dopamine. So if we're blocking that, we're increasing like levels. So again, we're getting increased levels of serotonin, norepinephrine, dopamine. A lot of the same. We're going to see a lot of the same symptoms with the other ones. Selegiline is a selective MAOB inhibitor. MAOB is the only one that breaks down dopamine. So MAOA and MAOB gets blocked by these guys, and they worked irreversibly. But just MAOB gets blocked by selegiline. So again, since it's increasing serotonin, norepinephrine, dopamine, you can give this for depression. You can give it for atypical depression, which is like it's just depression not presenting as normal depression. You can also give it for like your true depression, but again, SSRIs are going to be first line, and then also your treatment-resistant depression. Selegiline specifically is given for Parkinson's. And I just threw it in here. I didn't go into any of the other really Parkinson's meds, but this one is an MAO inhibitor, so I included it in here. Avoid taking with your tyramine-containing foods. So, for example, anything that contains tyramine, so aged meats, cheeses, and wines, this can trigger serotonin syndrome. If you're taking tons of cheeses, wines, aged meats, and then you also put them on an MAO inhibitor, it causes hypertensive crisis. Serotonin syndrome's down here. But for example, tyramine is broken down by MAOA, and now we're blocking MAOA, and now we eat tons of food with tyramine in it. There's no way to break it down. And tyramine is going to go into the blood, and then you have this hypersympathetic effect, which can cause hypertensive crisis. So how do you treat that? Phentolamine. So here's your treatment for that guy. But this is, again, specific for your MAO inhibitors if you take a tyramine-containing food, like cheese, wine, something like that. I feel like we got a question on this in our exam, too, where it was like patient was eating tons of cheese or something. They went to a wine and cheese night, and then it was like they had this hypertensive crisis, and it was like, what drug do you give them? Or what drug are they on? They're on an MAO inhibitor. Adverse effects for these, sexual dysfunction, so highest prevalence in all the antidepressants. So again, if it's you want to switch them from an SSRI to another one because of the sexual dysfunction aspects, you might not want to put them on an MAO inhibitor. Some orthostatic hypotension, weight gain, and serotonin syndrome. And again, this is only really if you give it with drugs that increase serotonin. So you give them an MAOA, but then they're also on a TCA, SSRI, SNRI. And again, hypertensive crisis, you treat with phentolamine. Your atypical antidepressants, mirtazapine, bupropion, all these guys. I think I meant to bold mirtazapine and bupropion. I think these are the most important ones. But they are going to, I don't think I finished. When I send this to you, I'll add my notes in here. I don't think I finished this one. So bupropion, these are going to inhibit those NET so the NET, which is basically norepinephrine transporters and your dopamine transporters. These are what bring norepinephrine and dopamine, in your presynaptic neuron. These are what are bringing the neurotransmitter to be released. So we're blocking that. So we're not allowing once it's out here, the transporter brings it back. So you can think of this too as it's inhibiting reuptake again. It's blocking that path back for reuptake. And then mirtazapine blocks alpha-2 receptors on presynaptic neurons. Your alpha-2 receptors are what's responsible for reuptake of all of these. Norepinephrine, dopamine, serotonin. It's the alpha-2 receptors. And fun fact, that's actually how Adderall works. Adderall blocks the alpha-2 receptors, so we're not getting reuptake of all of the neurotransmitters because it's primarily responsible via your alpha-2 receptors. Alpha-2 is alpha-2 is uptakes all of the reuptake, all these reuptake neurotransmitters.
There was this one thing in Boards and Beyond, I can send it to you, but it was saying how the alpha-2 receptors do something different on a presynaptic versus the postsynaptic neuron.
Okay.
And I was confused on what the differences were.
So I think alpha-2 on presynaptic, that's your reuptake guy. So that's going to reuptake norepinephrine, serotonin, dopamine. On the postsynaptic, it probably is acting through like non-specific alpha. Like if you get like an alpha blocker or like an alpha agonist that's not specific to alpha 1 or alpha 2. So you're probably going to get like those alpha agonist effects.
Yeah, that's what it was, but I don't
Yeah.
understand why it would be alpha agonist.
Well, it's what like if you're taking an alpha agonist, it'll bind through these, it'll activate these alpha receptors on the postsynaptic neuron and do what alpha, like if you agonize alpha 1, you're going to get like vasoconstriction, you're going to get like yeah, like orthostatic hypotension, things like that with alpha 1. Alpha 2 is like non-specific, but you can still get those alpha 1 similar effects with like just alpha receptors in general. They're G, what is it? G alpha Q? I forget. They're a G coupled protein receptor, but these alpha 2 receptors on the presynaptic, they don't do what alpha receptors do. They just re-up. That's all they do is they reuptake stuff. So
The
if you
alpha 2
block,
agonist.
yeah, the alpha 2s on the presynaptic, these are like your reuptake receptors. So if you block it, you're not allowing reuptake of norepinephrine, serotonin, dopamine, things like that. But if you block alpha 2 on the postsynaptic, that's going to basically be like you're taking an alpha inhibitor.
Okay. Wait, what would the symptoms be again for that again? Like for
Just
the
alpha
postsynaptic?
agonist.
It's like the hypertension and stuff.
Yeah, so alpha agonist would cause like vasoconstriction of your artery. So arterioles, you would get like vasoconstriction. You can also get, if you're blocking alpha receptors, you can get orthostatic hypotension.
God.
Yeah, and then I'll finish these two. I don't know why I stopped. I really hate the atypical antidepressants, so it's probably I was like, nope. Oh no, that's why. I see. I needed more room. Oh, I did finish it. Okay. So that's really interesting that I did it like that. And then I got rid of these guys, but then I added trazodone. Okay. Well, all right. So your atypical antidepressants, we talked about these two. So like, okay, so here's what it's doing. So it's blocking alpha 2 receptors on the presynaptic neurons. And remember, your alpha 2 receptors on presynaptic is responsible for reuptake. That's like its only job. It's not acting like a normal alpha 2. It's just reuptaking serotonin, norepinephrine, dopamine. So if we're blocking these, we're not allowing reuptake. So it's staying out here in this space. So increasing norepinephrine and serotonin. So it also has these, mirtazapine can also block serotonin receptor specifically. So 5-HT2, 5-HT3, I think that's a dash. And then it can also inhibit H1. So it also has those effects. Trazodone is a serotonin modulator. So this is a really good like modulator for serotonin because it's not only going to block serotonin receptors, it also blocks reuptake of serotonin. But it can also block alpha 1. So it kind of has anti-Ha effects because you're blocking alpha 1 and you're blocking histamine. So anti-Ha. So on this slide where I talked about all the symptoms of anti-HAMs, so here would be like your antihistamine effects and your alpha 1 effects that you could probably see. And that would be with trazodone specifically, your anti-Ha. No muscarinic effects with that. These can be first line for atypical depression. I mean, these are atypical antidepressants. But also bupropion has these CNS activating effects. So, for example, this would be a really good one for someone that has depression and also low energy symptoms. So, depression with hypersomnolence, depression with low energy. Bupropion would be really good because it also has this CNS activating effect. So if you had to pick one and they describe these symptoms, bupropion I feel like is like the most common atypical antidepressant. You can also give it for tobacco dependence, and then you can also give it for ADHD, off-label. Adverse effects. So this is kind of why I tried to make like color coordination with these. Remember I said like SSRIs, TCAs, like MAOIs, they can all cause like sexual dysfunction, weight gain, like all bad stuff where it's like the patient's like, I do not want to be put on a drug that causes sexual dysfunction, or I don't want to be on a drug that causes weight gain. You should think of like these atypical antidepressants, but you should know which ones cause sexual dysfunction and which ones don't, which ones cause weight gain, which ones don't. Because if you want to switch them to one, you need to know which one to switch them to, if that makes sense. So, for example, bupropion, yeah, it can induce seizures, but there's no weight gain, no sexual dysfunction. So that's why this might be a really good one to give to like a 22-year-old that has depression, but doesn't want to be put on a drug that's going to make them gain weight and have sexual dysfunction. So you might want to put them on bupropion. Mirtazapine still has those H1 effects, right? So it has these anti-H1 effects. So you can see sedation, so like they're very tired, as well as weight gain. They can still have some weight gain, but no sexual dysfunction. Trazodone, this is going to be your, this you can usually give, an adverse effect for this. So there is sexual dysfunction with trazodone. It can cause priapism. And this is due to the alpha-1 blockade, because remember, trazodone also is anti-Ha. So you are blocking alpha-1 receptors. So you can see priapism. Priapism is just one example of a sexual dysfunction. You can see other ones. And people remember this with trazobone, because it's like you can't get an erection. That's priapism. Trazobone. So again, that causes sexual dysfunction. It also causes histamine symptoms, so like something like sedation. And since it blocks 5-HT receptors and inhibits 5-HT reuptake, it's really big on serotonin. It can cause serotonin syndrome. Contraindications, so you don't want to give to patients that are bulimic or anorexic, because these patients are more likely to undergo seizures, and bupropion can induce seizures. So you don't want to give this to someone that's bulimic or anorexic. There are medications that are good to give for people that have bulimia and anorexia somewhere. Like SSRIs are good for bulimia. You don't want to put them on like something that can cause seizures. And then trazodone, you don't want to give it to the elderly. Again, your anti-H symptoms, never give it to the elderly. You can probably even add one here for mirtazapine. You don't want to give for the elderly. And then trazodone, you also don't want to give this to a patient with other CNS depressions like benzos or barbiturates. Okay. And then I just thought this was a cool slide from AMBOSS, which kind of shows where all these things are working. So remember your NETs and your DATs. These are going to be acted on by these guys. Your MAO inhibitors block MAO. So 5-HT, so here's your 5-HT2s down here. Mirtazapine can block the alpha-2s, but also can block the 5-HT2s. Your SSRIs block serotonin reuptake, so the SERT receptors. Did I miss anything else? Mirtazapine alpha-2. And then, remember adrenergic. These are going to be like your postsynaptic alpha-1 or alpha-2s down here, versus these are just strictly your alpha-2s. There's no alpha-1s on your presynaptic neuron. It's just the alpha-2s. Okay. All right. First generation. All right. So lastly, we have our last two slides. Oh man, antidepressant should be antipsychotic. Sorry. So these are going to be your antipsychotics. So we have one slide on your first generations and then one slide on your second generations. These are the ones that it's like you have to know all these names. I bolded every single one of them. You should know every single one of them. This is like your classic. I'm telling you, it's like their classic, like you're going to have a list of drugs. 4 of them are going to be like first gens and like one's going to be your second gen. And they're asking a question specifically about like a second gen. And it's like, okay, which one of these is the second gen? Like, I don't even remember. Or another thing I see is the high potency versus the low potency first gens. So know which ones are high potency, know which ones are low potency. Just everything you can possibly know about your antipsychotics, you should know. So haloperidol, I kind of separated out from the rest of the first gens because haloperidol has a very specific, thing that you give for it, basically. And I'll explain it. But so we have haloperidol, but then we also have fluphenazine, perfenazine, trifluperazine, pimozide, chlorpromazide, and thioridazine. So a lot of these end in azine, some of these don't, but at least the ones that end in azine, you're like, okay, these are your first generation antipsychotics. Another name for first generation antipsychotic is typical antipsychotic. So these are your typicals. And then haloperidol can also be a mood stabilizer, because of course it can. All right. All of these, so all of your first generation antipsychotics are going to block dopamine 2 receptors in the CNS. These are highly lipophilic, so they're going to last for a very long time. They last in your body for a very, very long time. But then they can break it down into high potency and low potency. High potency, it's like these are the very, very strong first generation antipsychotics. So they block like pretty much all of the only your dopamine 2 receptors in the CNS, but they pretty much block all of them. Versus your low potency, like chlorpromazine and thioridazine, these can block other receptors in addition to dopamine 2s. So that's why you have like your high potency, because they're doing what they need to do. They're blocking the dopamine 2s. But then your low potency, it's like they're blocking the dopamine 2s, but then they're also blocking some other like ancillary ones. All of these are anti-HAMs, all of them. So you see the antihistamine effects, anti-alpha-1 effects, and your anti-muscarinic effects. Okay, so when do you give a first-generation antipsychotic? So you would give anything for positive symptoms of schizophrenia, acute psychosis. So this is an example where you can give, it's not really a mood stabilizer, but you can give it for patients that are having like these acute psychotic breaks, basically. You can give them a first generation antipsychotic. Haloperidol, and this is why I kind of separated it. So haloperidol, something to understand about haloperidol, it's very strong, very strong. So they typically don't give it unless someone is literally so agitated. Like, you know, in movies when like patients are like in the psych ward and they're agitated and they're flaring everywhere and they get like a shot of something, it's usually haloperidol. And it works super quickly. They immediately chill out. That's like pretty much the only time you ever want to give haloperidol. Like I know down here too, I have like, yeah, you can give it as a mood stabilizer for bipolar, for both mania and maintenance, but usually they don't. They pretty much only give it for like these acute agitation. So I really think of haloperidol as like its own thing, because you probably wouldn't give it over something like trifluoperazine or flufenazine for something like schizophrenia. You would probably only give it for like these acute agitation, or this really like they're being really agitated or aggressive. You'd give them haloperidol. You can also give one of these for Tourette symptom management. Just again, but you'll know that they need an antipsychotic. They're having those like those symptoms you would think of for like psychosis or schizophrenia. All of these can induce torsade, just something they noticed, and all of them can lower the seizure threshold. So again, you would probably not want to give this to patients like that are bulimic or anorexic, because they can kind of probably trigger that seizure threshold. You might want to give like a second generation antipsychotic. So your high potency FGAs versus your low potency FGAs. So your high potencies, there's a very, very, very high effect of having extrapyramidal symptoms. And I have a chart at the end describing these extrapyramidal symptoms, and like what they are. But within minutes, you see acute dystonia. Within days, you can see akathisia. And then within weeks, you can see drug-induced Parkinsonism. And then eventually, you'll see tardive dyskinesia, which is irreversible. All these other ones are reversible, and I have the antidote. I made a whole other chart on these, because you should definitely recognize these and how to reverse, like basically how to reverse. Versus tardive dyskinesia, once you get here, irreversible. Other side effects, remember, we're blocking dopamine receptors, right? So you can see hyperprolactinemia, all the way back to first year Costanzo. Remember, if you block dopamine, you can see hyperprolactinemia. So if you see hyperprolactinemia, you can have galactorrhea. If you're a female, you can have amenorrhea. If you're a male, you can have impotence. Okay, that's like what kind of can happen. And then here's neuroleptic malignant syndrome. So it's going to sound very similar to serotonin syndrome, but remember, everything's going to be hypo. Like you're going to have hypo symptoms, like hyporeflexia and things like that. But everything else is going to sound pretty similar to serotonin syndrome. So like fever, lead pipe rigidity, altered mental status, autonomic instability. You can even have rhabdo and DKA. It's just like the body starts to like break down muscles and stuff. So that's neuroleptic malignant syndrome, usually triggered by your antipsychotics. Low potency is less of a likelihood that it's going to cause extrapyramidal symptoms, but now you're going to get those anti-HAM effects. So you're going to see sedation with the H1 receptor blockade, orthostatic hypotension with the alpha-1 receptor blockade, and then like all of those anti-muscarinic effects, dry mouth, constipation, blurred vision, urinary retention. And then the other two I put here, these are things that I noticed just from doing either, I forget if it was like UWorld questions or like specifically on my boards, I added these. Chlorpromazine causes corneal deposits. Thioridazine can cause retinal deposits. So I highlighted like the C and the C and the R and the R. And a lot of the times too, this is like one of those things, well, they'll describe, they'll describe symptoms of these anti-ham symptoms because these are both low potency ones. So they'll describe it and then say, oh, also there's corneal deposits, or oh, also there's retinal deposits. And it's like, okay, it's either chlorpromazine or thioridazine. Okay, and then your second gens, I highlighted, I think, the ones that are most important. Clozapine for sure, olanzapine for sure, risperidone, quietapine, ziprasidone, aripiprazole. I think these are the most important. Here are just some other ones that I've noticed just doing questions. So your second gens, they can call these, instead of second gen antipsychotics, they can call these atypical antipsychotics. Quietapine is also a mood stabilizer. So we have haloperidol and quietapine as mood stabilizers as well. And they're both on that mood stabilizer slide. These act the same way, but it's kind of going to be like your opioid receptor, like your fentanyls versus like the less intense opioid receptor blockers. So these block D2 receptors, but they do it in such a way where it's not as intense as your first gens. And that's the whole point of them making this second generation of antipsychotics, is because they wanted to make something like not as strong as the first gens. That's why they made these. Another thing that can happen is they can also block serotonin receptors. So you can see like it's so easy for them to ask about, neuroleptic malignant syndrome or serotonin syndrome. It's so easy for them to ask that. But remember, with serotonin syndrome, they also have to be on like a serotonin blocking medicine. So SSRIs, SNRIs, TCAs, MAOAs. So they have to be on one of those other things in order to have serotonin syndrome, versus neuroleptic malignant, it can just happen just being on the antipsychotics. They're all anti-hams, but again, and something you'll see, just like it's a theme with first gens versus second gens, all the first gens are going to be more intense. So a lot of the times why they switch someone from a first gen to a second gen is to decrease these symptoms. So we want to decrease like the amount of anti-ham symptoms. We want to decrease the amount of extrapyramidal symptoms. That's why you'd switch them from a first gen to a second gen. So anti-ham, everything we talked about. Clozapine is very big on blocking muscarinic receptors. It can be like a way of like understand. So even though it's like your second gens don't cause anti-ham as much, clozapine still, there's a higher in like likelihood that it's going to cause these anti-ham symptoms. And then I have here, overall, SGAs have a much lower affinity for muscarinic compared to FGAs, and that's why you would prescribe these over an FGA. Like let's say you have an elderly person. You don't want to put an elderly person on like a very strong anti-ham drug because they can't handle the histamine, they can't handle the muscarinic blocking effects, so you can put them on a second gen. Same thing as first gens for all the treatments. So like schizophrenia, treatment-resistant depression, Tourette's, and then specifically some of the more specific ones, risperidone, you can help manage OCD. So you can give it in addition with your SSRIs, which are first line. Quietapine, remember, can also be a mood stabilizer. So you can give it for acute mania and maintenance for bipolar. And I have here, like, again, you might prescribe an SGA over an FGA if the patient is experiencing bad side effects from the SGAs. So SGAs have the same side effect potential, but less likely. So they have the potential to cause these side effects, but it's a lot less likely than the first gens. Okay. Another thing about the second gens is they can cause metabolic syndrome. So think of just like someone with diabetes. Just imagine someone in your mind with diabetes, that like second gens can cause that. That's basically a metabolic syndrome. Side effects, we talked about extrapyramidals, but again, first gens are going to be more likely. Risperidone can especially cause extrapyramidal symptoms. Other side effects, exact same thing as your first gen, so hyperprolactinemia, go through that whole thing, you're blocking dopamine receptors. Torsade, neuroepileptic malignant syndrome. Specifically, olanzapine and clozapine, I think these are the most common second gens to know. You can get weight gain, hyperglycemia, dyslipidemia. These are your metabolic syndrome. This is basically your metabolic syndrome, so specifically olanzapine and clozapine can cause this. Clozapine only, and I've gotten this question before, so I highlighted it, can cause agranulocytosis. And how they're going to word this, they're not going to say patient has agranulocytosis. They're going to say patient has like decreased levels of white blood cells. Like their white blood cells are completely like very, very low. Like they're neutropenic. And you're like, oh, they're on clozapine. So if they talk about like an antipsychotic and now they have low neutrophils, oh, it's on clozapine. And it can cause other stuff as well. Okay, and then last slide is what are the extrapyramidal symptoms? Again, they're not going to say the patient has acute dystonia or akathisia. They're going to say these things. So, acute dystonia, like let's say you put them on haloperidol and you just put them on that instead of using it for acute treatment management, within hours and day, maybe like it can trigger these extrapyramidal symptoms. So, like within hours to days, here are the symptoms. So painful muscle spasms, mostly of the head, neck, and tongue. You can see torticollis. Remember torticollis from OMM? It can like get your neck to like just like tense in one direction. Oculogyric crisis is like with the eyes. It's kind of a similar thing with the eyes. It's like the eyes keep looking up, like you keep looking up and up and up and up. That's oculogyric crisis. And then tongue protrusion and twisting. Treatment. So know the treatments for these. So if they're describing acute dystonia, it's you give like an anticholinergic like benzotropine can be a good way to treat acute dystonia. You can also give an antihistamine like diphenhydramine, or you can give a benzo, but they usually don't like giving benzos. But you can give benztropine or an antihistamine of some sort. Okay. Next is, oh yeah, and I have the symptom up. I put them in the wrong order, but like adapt is how you remember the order. So it's acute dystonia, akathisia, like pseudo Parkinsonism, and then tardive dyskinesia. So I'm going to jump down to akathisia. This is like if you're still on the med that's causing these symptoms after like a few weeks, now it's like restlessness, you can't stop moving, like you just can't sit still. You're restless. For this, you would lower the dose, or you can switch to a second gen, because usually these are triggered by first gens, or you can put them on a beta blocker or a benzodiazepine. I think I've gotten this question before too, like you'd want to put them on like propranolol, for example, or like a benzo. Pseudo-Parkinsonism, it's exactly how it sounds. Usually this is after like months. I know I have 1 to 4 weeks, but usually it's months. It comes after the akathisia, and this is all, it goes in order. Like you would have all of these symptoms. So there should be no reason that you should get to tardive dyskinesia without like you should catch this in a patient. So after like months, you would see cogwheel rigidity. It's basically just sounds like Parkinson. It's like it sounds like they're describing a Parkinson patient. But they're on an antipsychotic, and you're like, no, this is the pseudo-Parkinsonism of the antipsychotic. So you can lower the dose, switch to an SGA, or give, again, benztropine. So here's benztropine multiple times. You can also give amantadine, which is a dopamine agonist, because we're blocking dopamine receptors. That's what's causing the pseudo-Parkinsonism. Let's give a dopamine agonist. And then finally, tardive dyskinesia. This is irreversible. You can't treat it, but you have to stop the drug because then they can like die, but they're still going to have tardive dyskinesia. This can happen after like years. And this is like what they describe classically in patients that are like lip smacking, repetitive chewing over and over again. They're making choreic movements, and it's just they're making these involuntary movements of the mouth, tongue, limbs, whatever. They're like, yeah, they're just doing a bunch of weird stuff. That's your tardive dyskinesia. And this is like, you can't reverse it, but you have to stop the drug. That's the only way to treat it. Okay.
For this chart, like what are the drugs that are causing all these things to happen again?
Usually your first generation antipsychotics. So here's your extrapyramidal symptoms. Second gens can cause it, but not as like your first gens are a lot more likely to cause extrapyramidal symptoms. Usually it's like just to help, if they describe one of these symptoms, usually they'll tell you in the vignette that the patient is on an antipsychotic of some sort. And maybe even that, it'll be like, again, when they list all the drugs that a patient's on, look for one of these first generation antipsychotics, because that's usually what's going to be causing these extrapyramidal symptoms. Okay. Yeah, that was it. That was all of them. You can
That
believe
was a
it.
lot, but I'm glad we did all of that in one session.
Yeah. I know. Sorry it was so long.
No, it's fine. It was so helpful. Like, because I've been doing